And breast cancer in itself is a humongous topic, and to cover it in just 2 hours, I mean, absolutely it is not possible. And today our webinar will be more focused was HER2 new positive breast cancer, and in the end, it will be concluded with a talk from an international speaker who will be talking regarding a new recurrence score which is applicable in hormone receptor positive breast cancer and which can serve as an alternative to those existing costly or time-taking options. So, moreover, our speakers and panelists, they are from, say, majority are from North India, but yes, we have one panelist from the South India, and besides that, from this part of the India also we have one panelist. So here I request all my colleagues and to be restricted to their time slot so that we can finish it in time. So starting with the first talk of the day, and this will be by Dr. Deepak Bharti. So he will be talking about this ADM1 in 2005, where it stands in my practice. So presently, as you are well aware, I mean, ADM1 we have for the timing, we have this option of even generic also available. So he will be talking about this ADM1, and moreover, this session is being supported by Zydus. Over to Dr. Deepak Bharti, please.
So I think my slides are visible to each and everyone.
Not yet. Not yet.
Not yet?
No, sir.
Slides are not visible?
No, sir.
No.
What's happening?
I think the layout is not coming out.
But I think it's working from my side.
Yeah, because I think it's a mobile, or are you on mobile?
Yes. Yes, I am using mobile. So it won't be working on that way?
No, no, it should be, but I think the format is little bit changed. Let me check, sir.
Then I think without wasting time, you will start sharing. I will just ask you the same thing because we don't want to waste in time.
Now
Okay.
now it's coming.
Now it's visible.
Yeah, it's good. Suraj, please take the charger.
Notes okay?
Yeah.
Yes, okay, fine. So, good evening, everyone. Thanks, Dr. Nadeem, for giving the opportunity. And we all know today we discuss about updates in breast cancer, and we will very important molecule, the history making, the first ADC or antibody drug conjugate, which has come into the data in the worldwide. And we just want to see because a lot of HER2 molecules have come in the market, where it stands and where is the indicated. And we will just discuss in last 10 minutes that how the data will support the drug and where we have to use this drug in our routine practice. So this is the sometime history that how the things are evolved, starting from trastuzumab to pertuzumab. What has happened? Something has happened in between. I think you are sharing.
Yes, sir. Your slide is not visible.
So you are sharing. Okay.
Yes, sir.
Okay, fine. So these are the all of the list of molecules which are there in the market, and it starts from trastuzumab to pertuzumab, some lapatinib and iratinib. Tucatinib is still not available in India. And on top of that, we started with the ADC in the form of TDM1. And recently, 2 years back, there is a TDXD has come into the market also, and it has taken some sort of relief and some sort of indicated point from TDM1. And we will discuss that how we stand the how to treatment in the present scenario. Please next. So as I told you, this is the first ADC to get approved for any solid tumor worldwide. Next. So we know there are two types of breast cancer. We have to treat the one is early, one is the metastatic. For early, we mean that in any point of time, a T score of T1C or any node positive, we have to treat this patient as early breast cancer with the form of neoadjuvant chemotherapy. And in some certain patients, we can add trastuzumab, and certain one we can add pertuzumab. That's a different topic of concern. And if any point of time, at the time of surgery, in the histopathology, patient is not able to receive the PCR, then we have to put the patient on TDM1. This is the current standard of care, and we are still sticking to that one only in the form of Catherine trial. And in 2013, there's a trial for the metastatic breast cancer, but they have shown that in any patient in the second line of setting, if the patient get progressed after getting any line of HER2 treatment or get recurrence within 6 months of completing adjuvant therapy. So that are the two indications for metastatic breast cancer for TDM1, and for early breast cancer, if someone not achieve the PCR, we have to put this patient on TDM1. Next. And the trial we supported the both indications. For early is the Catherine, and for another one is the attempt trial. Next. Okay, so certain points for the Catherine trial, well-designed trial, which for the neoadjuvant therapy for minimum 6 cycles of chemo and minimum 9 weeks of trastuzumab or 3 cycles of that. And we have to see the invasive tumor either in the primary or in the axillary nodes, and we have to randomize the patient after 3 months. And the good number of patients for 1486, 1:1 ratio. Either patient will continue on trastuzumab, or the patient will not get the PCR. We put the patient on TDM1, 3.6 mg per kg, fixed doses, 14 for 14 cycles. Next. So concern is regarding the invasive disease-free survival, and till now it is a long-term data of touching 8.4 years is still with us, and we know that how we can things get improved, because we have to see the patient for invasive drug-free interval. Next. Okay, so just leave the Kaplan-Meier curve. After 7 years, there's a 13% more benefit shown by in the TDM1 arm as compared to trastuzumab arm. And it started from the 3 years, just see the decrease, it's 88, 84, and 80. So just a little bit of 4% declining is there as for the 2 years as concerned, with hazard ratio of 0.54, 46% mortality benefit. So point is that is the recent updated IDFS in the published in the 2023 service, and it has shown that even after all along the things, we are still, it's good to put this patient on this TDM1. And the concept has been started by the Catherine trial, because way back, because we are following the trastuzumab only, even after patient not getting the PCR. The new concept of PACR started by Catherine trial, and after that it has changed the scenario of treatment and management of breast cancer HER2 positive patients. And this way we can show that 30% benefit is a number to say. Next. Okay, regarding the overall survival, it is still not replica of other way around, but still 5% overall benefit after 7 years. It's still a good number, and it's obviously hazardly, and all the way is p-value significant with hazard ratio 0.66. So all way the trial is approved, and it has shown the indication of TDM1 in the present area also, and still for the last 7 years we are following this indication at this subset. Next. And just I want to highlight all the subgroup analysis, like stage or hormone positive or negative or preoperative trastuzumab received or not received. Even someone has received a dual anti-HER2, node positive or negative. In all the, in more moderate race also, white, black, or Asian. In all the subset, patients are getting benefit from the TDM1 group as compared to the trastuzumab group. Next. And 2 points I want to highlight, which I've already circled in red and green. The patient who are getting the small residual disease, just I want to highlight that even in T1A, T1B, or MIC or TAS also, even they are the one who are getting benefit after addition of TDM1. Because certainly in the clinical we know that the patient put on trastuzumab, and we know that patient we achieved T1A or T1S. We know that okay, the things that we have got the thing we can't do with trastuzumab only. But this is not the case. What data is showing that it is touching 8% benefit after addition of TDM1 in that group also. Similarly, for the patient who are getting the PCR with not equally with MIC or YN0 also, they're also getting benefit of touching 9%. So even the patient with small residual disease left behind, even after getting the surgery or neoadjuvant chemotherapy, we are still the data is promising for the TN1 group only. Next. So this way we are planning our managing patient. This is a flow chart. Newly diagnosed high risk patient with early breast cancer, we can put on chemo plus trastuzumab. We can do the surgery. We assess the residual disease. If patient has not received the PCR, obviously we have to put the patient on TDM1. And if someone achieve the PCR, we will continue with the same HER2, either dual or anti or single, whatever we are using in the neoadjuvant setting. Next. This one is highlighted in the recent 2025 guidelines also. A patient with complete PCR started with the same HER2, what are their use, either single or dual, and if someone has not achieved the PCR in both the groups, category 1 indication for the TD1 is there. Next. So these are certain of the trials for metastatic breast cancer in the form of Amelia, Larissa, Camellia, and Marine and real world studies also confirm the things. Basically, it is a second line drug for metastatic setting. First line is still holds for the chemo and trastuzumab or pertuzumab. Although things have changed for the last 1 or 2 years, we will discuss in the future slides. And more important, two, three things is there. Camellia shown that it has a better CNS activity also. So these all trials are supporting TDM1 in the second line settings, and all the data we will discuss in the future slides. Next. Okay, starting with the Emilia trial, because little bit we are confused regarding the second line setting when a patient got progressed after the first line of anti-HER2. Either we start with lab cap or TDM1. Although in my practice, I started with TDM1 only, but in certain patients who are not like financiers or other way around, we can start the things. The patient not fit enough for these things. We start with lab cap only, but data really confirm that TDM1 holds far superiority than the lab cap. Regarding Thresher trial, it's a TDM versus treatment physician choice, either chemotherapy or any other thing what they want to use. And similarly, they have shown that the patients are getting more benefit with the TDM1. It's Emilia for the second line and Thresher is for the beyond second line. So in both the settings, TDM1 holds true. Next. So PFS and OS benefit for the Emilia trial. So way back, you just see the 3 months PFS benefit shown by the Emilia trial TDM1 group. And regarding the, if you want to see the overall survival, it is touching 13% more benefit shown in the TDM1 group. So in both ways, with the number numerically and statistically, Emilia trial TDM1 shown statistically significant from lab cap. Next. So regarding the, and whenever we see the drugs, obviously it comes with certain specific side effects also. What we want to, it's not that what the trials have shown that, but what has happened in the year, but it's absolutely different. We know two things are very peculiar with the TDM1. One is the fatigability or asthenia, and number two is the patient who are getting the certain lung symptoms in the form of ILD or edema, other way around. These are routine things which we are seeing in our routine patients, what we are treating in real world patients. Diarrhea is there. And what we want to highlight is there that in lab cap, we have 57% more event grades as compared to 40%. So TD1 is little bit safer as compared to lab cap because patients are not able to use full lab dose also in routine practice. Next. So this is another trial where we have to use a TDM1 beyond the second line. Just I want to highlight two things: 3 months benefit in PFS and 7 months in OS. In the third line setting, HER2 positive patient, metastatic, anything close to 7 months OS benefit in the third or fourth line, it's good drug to go. And both the Kaplan-Meier curves prove the same thing. Next. So number third point is the CNS activity. We all know that LabCap is a drug which have CNS activity also, but TDM1 is also not far behind. It also has a CNS activity and more towards the TDM1 because I want to highlight the two things. If you want to see the blue group is for the TDM1 and the pink line is for the LabCap. So both things have shown that that TDM1 has the activity regarding the brain. Similarly, LabCap also not stand behind, but some way for the median PFS benefit, no CNS mets also there. Both things, if patient is not having the CNS mets per se, then patient we can put on both LabCap and TDM1 because in view of decrease the time duration for getting CNS mets. And if someone has the CNS mets, definitely we can go with any other drug, but both have the CNS activity at present. Next. So regarding the this Camellia trial, which regarding the brain, is the brain lesion shrinkage was observed, and that I want to highlight that is a waterfall plot, and what they have shown that 43% patients with measurable disease had more than 30% decrease in summer large diameter. So these things have proved that it's not like the routine things which can have proved. Good number of patients are getting response from the CNS penetration and disease also, and this way we can good to use this drug because there are a lot of drugs that also come in the into the market which we have the better CNS penetration apart from trastuzumab and pertuzumab per se, and TDM1, LabCap, and TDXD are the other ones which have a better brain penetration. Next. So its first line marine trial is there. Although the trial has not yet get approved for the things, it's a phase 3 trial, it's a metastatic or locally advanced things. There are three way they have randomized trastuzumab plus chemotherapy, taxane, anyone, TDM1 plus placebo and TDM1 pertuzumab. So there they have used pertuzumab also with that. So what they have endpoint is that is the PFS. So point of concern is there is that if patient after getting chemotherapy, more than 6 months of that get recurrence, and patient with touching 1095 with three parts are there, whether we start with the chemotherapy and continue with the same drug of trastuzumab, or we give single TDM1, or we have to add pertuzumab with TDM1. This is what and good better way design trial is there, but I think that the trial is little bit for way back, because certain things has come back in the form of FESGO and other way around, which have make this trial not so familiar. Next. Okay, so regarding the benefit point of we want to discuss, it is the 13.7 versus 14.1, touching 0.4% benefit is shown by TDM1. But the highlight point is there is that the TD1 treatment of patients with positive metastatic breast cancer were deemed unsuitable for taxane-based therapy. So whosoever is not good for taxane, you can shift with the TD1. And if fewer neutropenia and diarrhea alopecia shown with the TD1 arm as compared to other way around. So in both ways, touching benefit is there. But if you want to highlight 2 points, TDM1 7.7, TDM1 per 2 is 9 only. So touching 1 month benefit shown by the addition of pertuzumab, and lot of side effects are there with the addition of pertuzumab. So in all the three randomized trial, still TDM1 holds true if someone wants to use in the first line, after the if someone gets progress after the adjuvant setting. Next. So this is what the global strategy we are following at the in the present era. That if someone with HER2 advanced breast cancer get relapse within 12 months after completing the new adjuvant therapy, obviously we have to see the brain, especially for we have to do the PET scan plus MRI brain. If someone has the brain mets, obviously this time by book we have to follow tucatinib and capacitinib plus trastuzumab. Although this drug is not available in India, and what we have it is a TDXD, which has not yet got the first line approval. And if someone has the no CNS metastasis or stable brain metastasis there, we can put this patient on TDXD, then tucatinib. So point of concern is that active meds, tucatinib is the far superior drug at present for the brain metastasis as per TDXD. And if someone get progress after that, then we put based on TDM1. So TDM1 got shifted from second to third line with the addition of TDXD in the present era. Although tucatinib is not yet available, and most of patients not in our Indian setup or in our society, patients are not able to get the TDXD, and TDM1 is still little bit financially acceptable to most of our patients. But by book, we have to follow that TDXD, then tucatinib, then TDM1. This comes to the third line in the advanced setting only. But in the early setting, we are still good to use TDM1, that following the Catherine trial, that if someone not get the PCR, we have to put the patient on TDM1. So in metastatic setting, TDM1 has skipped one line beyond, but regarding early, it still holds true. Next. So what we saying that TDM1 unmet need, large number of deserving patients for this drug in India, but CES and biosimilars were not there. Initially, it's for Roche only, but 4 years back, Zydus has come up with this biosimilar, and certain things we will discuss that how this biosimilar is equivalent to the innovator. What the trial has been shown for that. Next. So regarding most importantly, efficacy and safety. These are two factors which will decide whether biosimilar and innovator are both same or not. Obviously, it has head to hand with the Catsila, and good number of patients they have enrolled, and all the four factors: efficacy, safety, pharmacokinetics, and antibodies. All it has shown that it is absolutely similar to the innovator. Although certain things are still way behind, and that things are acceptable to the pharmacokinetics. Next. Okay, so this is a trial which have shown that with the form of comparison with this thing, and especially from India only, done by Satish, and is a phase 3 trial and published in 2021. And what they have shown that this is an open label trial. It is efficacy, safety, immunogenicity is absolutely equivalent to the innovator arm. Next. So last, not the least, it's the asthma and ASCO conference data in TDM1. I think next. Next. So this is abstract published from Hyderabad, Dr. Senthil Rajappa, and is I think is a student. It is single center efficacy and safety data from generic TDM1 Institute of Experience. Next. So what they have included 116 patients, 44% are adjuvant, 56% are advanced setting, and most of them have completed the treatment, 62%, both in adjuvant, and 46% of patients have got progressed in this setting. So these are data combined from that center only, and what they have shown up. I just want to focus on the OS and PFS. Next. So these are the curves they have shown that all the way around this of efficacy point and is almost equivalent to what we have seen in the innovator arm. Next. Okay, there are certain side effects, but I just want to tell you that certain patients and race will have different side effects. Diarrhea holds number one here also, and in certain patients, fatigue number three. In our we know that fatigue is very common complaint from our Indian patients. Next. So this is a trial and also some study efficacy and safety of TDM1 HER2 positive is also from India. All the things are there. Median PFS of 12 months they have shown, and all the way around good number of 100 patients they have taken out. Overall response rates of 45%. So these all are data supporting the TDM1, especially from outside, and as one, especially from India also. Next. Thank you. So, cut short of things, I just want to tell one thing that TDM1 is a very important molecule for the HER2 metastatic and early breast cancer. For early breast cancer, it still holds true as for following Catherine. And regarding metastatic setting, we are still TDXD has little bit taken the role of TDM1, but it's not still out. It is come from second to third line. Thanks a lot. If any question, I'd love to answer.
Dr. Deepak, I would like to learn from you. I mean, what is your experience regarding the toxicity of TDM1? I mean, what was the common toxicity which you encountered, and what was the, I mean, dose? Do you ever require dose reduction? And
Yes, I will just discuss three patients. One of my patients getting severe as fatigue. So only, but rest part of is okay, but it's because of fatigue, we have to stop the drug after 2 or 3 doses. Number two, the one patient of anecdotal case, I got ILD. Number three, there's a young female post 2 lines of HER2 treatment. We have started the patient on because of financial aspect also. I have given underdoses. The patient is fit for 200, but I am giving 160 only, keeping cost into consideration. And that lady, for the last, I think, 9 to 10 months, still doing good in CR. So all the things are happening out we are seeing in a mixture regarding ILD, regarding fatigability, regarding patient underdosing, and still getting benefit. So it's all there. We can see.
I mean, what is the, I mean, any experience regarding the, do people get hepatitis? I mean, elevated liver enzyme? Because one of my patients, her dose was 260, but barely I was able to cross 200.
Okay, so they are regarding hepatitis. I will tell you, I have seen one patient when I was doing my training in Artemis. That lady at the time was getting Katsila only. I think 74th or 75th dose of Katsila she's on, and after I think last 3 4 after 70 doses she had got CLD, and prior to that she got the hepatitis. So there are another causes like this edema, OTPT days. I'm not seeing in routine patients, but fatigability, ILD in one patient, and apart from that, certain thrombocytopenia and anemia are still there. Then hepatitis, I've just seen the one patient only, but that too after 65 or 60 doses of Cadsilla.
Thank you. Thank you. If you have any other questions, we can take up.
No, my Dr. Nadeem. So my experience with the this drug Ujvira, it's also very good. I have a patient. She's almost, I think, 2.5 years metastatic with brain mets, and she's in CR. And the beauty is that there is no alopecia also. So I'm very comfortable with this. Thank you.
Yes. Yes, sir. Thank you. Thank you, sir. So, I think we can move on to the next topic. That is by Dr. Burhan, who is working as a senior consultant in medical oncology at AOI Jalandhar. And Dr. Burhan will be talking regarding the role of FASGO in early and metastatic HER2 positive breast cancer. So, as we are well aware, I mean, how FASGO has really revolutionized the timing of the administration of those two drugs. So over to Dr. Burhan.
Thank you, Nadeem. Good evening to everyone. At that outset, I would like to thank you for inviting me for this breast cancer update. And as you pointed out, my talk will be focused on the FESGO, that is the combination, fixed dose combination of the trastuzumab and the pertuzumab. So the topic is to transform the journey for the HER2 positive breast cancer patients. So the disclaimer from my side is that this has been sponsored by the Roche, and I have been all the study material is from the Roche. So if we see as far as of current standard of care for the breast cancer care patient is concerned, that is a HER2 positive early breast cancer patients. So if a patient is a newly diagnosed, so majority of these patients are now being exposed to the what we call as the neoadjuvant therapy. So the neoadjuvant therapy has its own advantages. So the advantages include it can avoid a mastectomy and enable the breast cancer conserving surgery. But I think the most important thing that we see in the as far as the HER2 positive breast cancer patient is concerned is that we are looking into the pathological complete responses, which serves as a surrogate marker for the survival in these patients. So current guidelines, they recommend the use of neoadjuvant treatment for stage 2 and stage 3 breast cancer patients who are HER2 positive. So the data for it came from number of trials. We have the NeoSphere trial. It was a neoadjuvant study of pertuzumab and trastuzumab in early regimen evaluation. So NeoSphere trial, it was a phase 2 trial that showed the pertuzumab in the neoadjuvant setting, where there were 4 arms, where pertuzumab with trastuzumab along with docetaxel was one of the arms. Then the other arms include the trastuzumab with docetaxel. The third arm was pertuzumab, trastuzumab alone, and the fourth was the pertuzumab with docetaxel. So the NeoSphere study, the primary endpoints was to study the pathological complete response at the time of this surgery. So they compare the various arms for this primary endpoint, and the secondary endpoints were the safety, PFS, and the disease-free survival. So if we see this pathological study design and the pathological complete responses, so almost we had on 107 patients across the various arms, and the patients were given the treatment, which included the trastuzumab and docetaxel, and then in the study arm, which was the pertuzumab, trastuzumab and docetaxel. If we see the pathological complete responses across the various arms, the maximum was seen with the triple drug regimen, which was pertuzumab, trastuzumab, and the docetaxel, that showed a pathological complete response of almost 46%. So similar, it was reported for the PFS in the intention to treat population. Here we can see the curves. The maximum benefit is for the PFS was for the patients who had both the trastuzumab, pertuzumab, and the docetaxel in the neoadjuvant setting. And the same for reported for the disease-free survival as well for the intent to treat population. And this is the 5-year follow-up of the trial, which was reported. Then PFS, it showed that patients who achieved pathological complete responses, they derived the maximum benefit as far as the pertuzumab, trastuzumab, and the chemotherapy was concerned. So overall tolerability was good. The patients were tolerated the regimen, and there were no significant changes as far as detected, including the cardiac toxicity that was reported, that was similar across the various arms. So the NeoSphere study, it showed that the combination of pertuzumab with trastuzumab along with chemotherapy, it significantly increased the pathological complete response rates without substantial differences in the tolerability. And overall, patients who achieved pathological complete response, they had the reduced risk of uh, the reduced risk of progression or invasive disease recurrences. And there were no new or long-term safety constraints that were seen with this combination. So if we see all the pooled analysis of the neoadjuvant trial across the various studies that were conducted, all of the studies, they have shown that patients who had achieved pathological complete response, they derived a long-term outcome than those who had the residual disease, irrespective of whether they were hormone receptor positive or the negative. So pathological complete response, achieving pathological complete response is one of the important factor as far as the HER2 positive breast cancer patients are concerned in the neoadjuvant setting. Now, there we have a data as far as the adjuvant settings also of the role of pertuzumab with trastuzumab is concerned. So we had the affinity trial, which we had the final analysis on the OS. So this affinity trial, it was a phase 3 double-blind randomized adjuvant study, which were trial, which showed the patients where after surgery, they were randomized to chemotherapy along with the combination of pertuzumab and trastuzumab versus the chemotherapy with placebo plus trastuzumab. And if we see here, there were many analyses that were done. That was the primary analysis at 3 years, at 6 years, at the second interim analysis, then that third year, at 8 years, the third interim analysis was done, and at 10 years, the final analysis was done. So all these they found that at the final analysis, the Perjeta plus the Herceptin, that is the combination of pertuzumab and trastuzumab, it resulted in 21% risk reduction compared with the placebo plus Herceptin, with an absolute delta of 3.4% in the invasive disease-free survival, and which demonstrated that invasive disease-free survival benefit of this combination was maintained after the long follow-up. So here again, we can see that this was the final analysis reported. So there was a maximum as far as the difference was seen. And after medium follow-up of 11.3 months, the differences in the incidence of distant recurrences between the treatment arms, it was 2.5%, with fewer distant recurrences in the Perjeta and Herceptin arm. And the maximum benefit was seen in patients who were node positive subgroup. And here the delta was reported to be 4.9%. So this is the final analysis across the various subgroups. And we can see here for node positive patients, it reported a hazard ratio of 0.74. And for patients where irrespective of the hormone receptor status, it was benefited if they were node positive. So as far as the OS is concerned, in the final analysis, they showed that patients who had the node positivity disease and they were given the Herceptin and the Perjeta in the adjuvant setting, they derived the OS benefit as well. And here the hazard ratio was reported to be 0.79 compared to patients who were node negative. So overall, there was a 21% reduction in the risk of death and the absolute OS benefit of 2.7% that was reported in node positive breast cancer patients, HER2 positive. Now, if we come to the metastatic or the advanced the breast cancer, HER2 positive breast cancer patients, currently we have the across the various guidelines. So transatlantic, whether it is in the NCCN or in the ESMO guidelines or ESCO guidelines, all of the guidelines have recommended to use the combination of pertuzumab with trastuzumab with chemotherapy in the upfront setting in these patients. And this is based on the Cleopatra trial, which was a phase 3 trial that established this combination with chemotherapy as a standard of care for the first-line treatment of HER2 positive breast cancer patients. So here the patients, they were randomized to two arms where the Herceptin along with the chemotherapy was given in one arm, and in the other arm, the combination of pertuzumab with trastuzumab with docetaxel was given, followed by the maintenance in both the arms. And if we see here the PFS benefit, here the Kaplan-Meier curves, they are wide apart. So again, they showed that in the combination arm, the PFS that was median PFS was reported to be 8.7 months versus in the trastuzumab chemotherapy arm, it was around 12.4 months with a hazard ratio of 0.09. Same was reported in the overall survival as well. Again, the median overall survival for the combination was reported to be 5.1 months versus 40.8 months with a hazard ratio of 0.69. So the incidence of the adverse effects, if we see, they were well tolerated across and there were no new safety signals that were reported. And at 10 years follow-up, there were higher incidence of diarrheas and rash that was seen with the Perjeta compared to placebo. It was of any grade and grade 3. Neutropenia, they were reported in all the patient populations in both the patient groups. So there were adverse effects as well. So if we see the overall response rates with the combination of the Perjeta in that is the pertuzumab in the first line setting, it was reported to be to the tune of 80% overall response rates. And the duration of response was almost doubled once we used the pertuzumab with trastuzumab in the first line setting of metastatic breast cancer patient. So there was almost 7.7 months improvement as far as the duration of response was concerned. So the problem that we face is that once we are giving a combination of the pertuzumab and trastuzumab, we are giving it an IV formulation. So there are the problems that arise is that we have long infusion or observation times, and which leads to the congestion at the clinics and the hospitals, challenges as far as improving the hospital resources, placement and maintenance of indwelling venous catheters, because these patients are giving for a longer period of time the maintenance therapy. And some of the patients, they have the challenges as far as the excess venous access is concerned. So to overcome this, the first FESGO was launched, which was the first formulation in oncology that combined the two monoclonal antibodies, that was pertuzumab and trastuzumab, in a single vial. And it is a in this vial we have both the antibodies which are being given, and besides that there is a hyaluronidase which allows the subcutaneous administration of higher dose volumes, around 15 ml at the loading dose and a 10 ml at the maintenance dose. And it is a ready to use formulation which is given by subcutaneous injection in the thigh. Most of the times it takes around 8 to 10 minutes to finish this thing. So there were a number of things that were actually looked into once this fixed dose combination was given. So first was about to study the whether inferior non-inferiority study, whether it was the Fredica study, which was a phase 3 non-inferiority study to assess the pharmacokinetics, efficacy and safety of the fixed dose combination as the FESGO subcutaneous versus the pertuzumab and trastuzumab in the IV formulation. And here it was reported that the fixed dose combination, that is the FESGO, it was non-inferior to the IV combination based on the cycle 7, the trastuzumab and pertuzumab trough levels. So again, if we see as far as the responses is concerned, there was almost identical pathological complete response that was reported with FESGO vis-a-vis the IV pertuzumab and the trastuzumab. The safety signals, again, they were comparable between the FESGO and the IV formulations, and the rates of treatment discontinuation due to adverse effects, they were similar between the two arms. As far as the incidence of other toxicities was concerned, they were there. Although we know that diarrheas, neutropenias, and cardiac dysfunction, but they were almost similar between the two groups. So this study showed that was a non-inferiority pharmacokinetics was established between the FESGO versus the IV formulation of pertuzumab and trastuzumab. Now, another study that was done, it was the Ferenska study. It was a phase 2 study that assessed the patient preference for fixed dose subcutaneous formulation, that's the FESGO versus the IV. And here the maximum majority of the patient, they vouched for the FESGO, and they found it was highly strongly and highly the preference was given to this molecule. And the reasons were because of the less time in the clinic and more comfortable during the administration. So the most of the patient, they reported a very satisfied with the FESGO versus the IV formulation. So majority of the healthcare practitioners, they felt their switching from the IVs to subcutaneous would save the time and the resources. And this is again 85% of patients, they preferred for the fixed dose combination versus the IV formulation. So if we see that Phesgo currently it provides the benefit as far as the cost, time, and reduction of the patient and the hospital healthcare burden is concerned. It has the shortest administration time of around 5 to 8 minutes and the observation of 15 to 30 minutes of Phesgo, which reduces the burden on patients, caregivers, and the providers. Phesgo has the less invasive administration versus the IV, freeing patients from the burden of IV-related pain, bruising, and irritation. Fixed dose formulation, it may reduce the risk of dosing errors, reduce the drug wastage, and increase the availability of nursing and pharmacy staff for other tasks. And there were no new safety signals that were observed when switching from the IV to the Phesgo or vice versa was concerned. So doing now what matters the most is should be done for the patients. And with this, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Burhan, for this wonderful talk. So I just want to, learn from your experience. Will you, where do you place the usage of adriamycin in HER2 positive early breast cancer? Do you still consider to use it?
No, if I'm giving currently if I'm giving pertuzumab, so I'm not give. I think off late I have almost declare. You can say that reduce the use of anthracyclines in the HER2 positive breast cancer because of better availability and tolerability of these regimens that we have for HER2 positive breast cancer patients. And also the cost of the treatment has come significantly down as far as pertuzumab, trastuzumab, and the chemotherapy is concerned. So it becomes easy for the patients as well to actually to tolerate these regimens and to afford these regimens and to derive the maximum benefit.
Thank you. Thank you. We do have a data also, to support it. So moving on to the next talk, that is by Dr. Sandeep sir, and who is from Chandigarh, who works as a in this senior consultant in Sohana Hospital. So Dr. Sandeep sir will be talking regarding this NHER2, this trastuzumab deruxtecan for the treatment of this HER2 low or ultra low metastatic breast cancer. Because till date we are well aware that how trastuzumab deruxtecan works in HER2 positive breast cancer. But today he will be talking regarding the HER2 low positive or ultra low metastatic breast cancer. So over to Sandeep sir.
Yeah, Dr. Nadeem, first of all, thank you for the invite, and I'm really elated to give my talk on this new topic, which is now you can consider it as one of the standard of cares in HER2 low or HER2 ultra low MBCs. As I'm traveling, so I will be putting my video as on a video off mode, stop mode, so that the voice is uninterrupted. So I'll also request the organizers to share the slides and take it forward then. Next slide, please. So we all know, as Dr. Nadeem was talking about, that we have a data in HER2 positive breast cancers, whether it is the metastatic settings, but now we have seen that going forwards in the hormone positive settings, you have an unmet need where patients beyond a certain line of therapy, either the first line or the second line hormonal therapies, there are no further treatment options apart from chemotherapy that are left. So there have also been a heterogeneity in the testing of HER2 positive cancers, where, as a blanket, if the patient is HER2 2 plus fish negative, we all consider it as HER2 negative cancers. But we all know from our experiences that all these HER2 0, HER2 plus 1, plus 2, and plus 3, they all behave differently. So that is why this population was tested against the then today's standard of care, that is the TDXD, whether it works in HER2 low or the HER2 ultra low settings. So several takeaways will be there from this session as well, whether we want to give this treatment to low or ultra low or not. And secondly, it can be considered as a potential therapeutic option, considering the fact that apart from 2 lines of hormonal therapies, 2 or 3 lines of hormonal therapies, we don't have further treatment options left for these patients apart from subjecting them to chemotherapy. Next slide, please. So this was about the HER2 HR positive and HER2 negative cancers. And we all know that if you look at the overall population of HER2 plus 1, this will account for around 60 to 65% of the patients. And it is the IHC 0 with membrane staining will be around 20 to 25%. So if you consider the entire cohort, they will account for around 80 to 85% of the patients who can be challenged with this potential therapeutic option. Next slide, please. So this is about, we are talking about DB03, that is targeting low or ultra low, that is +1 to 0 with IHC. Next slide, please. So there has been an unmet need in HR positive, HER2 negative MBCs if you consider the HER2 staging. Next slide, please. So this is the current landscape of treatment in terms of median progression-free survival. That is the first line ET and CDK4/6. They give a survival benefit. They give a progression-free survival benefit of around 2 years. But if you go beyond third line, there are very few treatment options left. Either offering them a single agent hormonal therapy or giving them a single agent chemotherapy. But now this second line and beyond has been tested with the standard of care today's world in TDXD, which as per the trial, the median progression-free survival benefit is to the tune of around a year. Next slide, please. So we all know about the mechanism of action of NHER2. Next slide, please. So NHER2 is basically an antibody drug conjugate, which acts as where the payload acts as a topoisomerase 1 inhibitor after being internalized via the HER2 receptor. Next slide, please. So this is a DB06 study design where HR positive MBCs that were HER2 low, that is +1 and +2, or HER2 ultra low, that is IHC 0 with membrane staining, and those who were chemo naive. So important to understand, the patients had received more than 2 lines of endocrine therapy plus minus targeted therapy for MBCs, or had received one line in MBCs and what we consider as the refractory patients, that is primary refractory. Either there was a recurrence in less than 6 months of starting and line with CDK4/6, or a recurrence in the adjuvant setting after less than 2 years of treatment. So they were randomized to 2 different arms, that is TDXD versus the treatment choice of treatment chosen by physician, where chemotherapy in terms of capecitabine, nab-paclitaxel or paclitaxel was administered. And the primary endpoint was a progression-free survival benefit, particularly in the HER2 low, that is IHC +1 or IHC +2, and ISH or FISH negative. And the key secondary endpoint was testing for progression-free survival benefit in the ITT population, that is low and ultra low, and demonstrating an overall survival benefit again in the low and the ITT population. Next slide, please. So you have a study design where beyond the 2 lines of therapy, particularly in the MBC setting, that is the real world setting, where the patient has been treated with hormonal therapies, now you are subjecting them to a targeted form of treatment, either with ADC or testing them against the physician choice of chemotherapy. So the arms were well balanced in terms of the baseline characteristics. Next slide, please. So this is about, sorry, go back to the previous slide. So this is about the ER/PR status. You can see here that almost around 87 to 90% of the patients were ER positive, either ER/PR positive or ER positive. And if you look at the primary resistance of the diagnosis, then it was around 30% of the patients were primary endocrine resistant. If you look at the visceral disease, that was present in majority of the cases. Next slide, please. So majority of the patients, if you look at the number of lines of treatment, majority of the patients in a real world as if they had received more than 2 lines of therapy. Important to highlight only this point. Next slide, please. So next slide, please. We are going through the details of what the DB06 data in the next slide, please. So go back to previous slide. I think the data from the PFS. Next slide, please. Next slide. So this is about the forest plot. I think they have the presentation has been omitted because I think there were two different slides where the progression-free benefit in terms of progression-free survival benefit in terms of the ITT population and in terms of the HER2 low population was demonstrated. And it clearly demonstrated that there is a delta of around 5.1 months in the HER2 low population, that is 13.3 months versus 7 months of treatment, particularly in the HER2 low, and the same was reflected even in the patients with HER2 ultra low population. So the Kaplan-Meier curves that you are seeing here, it is showing that the progression-free survival in terms of time to progression on first-line endocrine and CDK4/6, that is, if the patients had progressed in less than 6 months, 6 to 12 months, and more than 12 months. So, the majority of the patients who had a primary endocrine resistance, they definitely benefited from the treatment. And the delta of benefit, if you see, it was way high if the patients had progressed more than 12 months after the treatment with first line ET and CDK4/6 inhibitors. That is, with the TDXD, there was a PFS benefit of around 14 months versus a benefit of around 8.2 months in patients who had progressed beyond 12 months of treatment. Next slide, please. So if you look at the PFS2, that is after the randomization to the second progression. So there was again a delay in the PFS2 was seen, clinically meaningful benefit in with TDXT compared to the compared to the TPC based population. Next slide, please. So PFS in terms of measures of disease burden, even if you look at the number of sites, whether the number of sites were less than 3 or whether the number of sites were more than 3, the delta of difference between the two Kaplan-Meier curves is there. Particularly, predominantly, if the lesser number of metastatic sites are there, the delta is to the tune of around 7 months, whereas the delta of difference to the tune of 4.2 months was seen if the number of metastatic sites is more than 3. And now there was a notable difference was seen if the patient has visceral metastasis versus no visceral metastasis. So you look at the hazards. If there are no visceral mets, the hazard is to the tune of 0.5, whereas it is 0.65 if a patient has visceral disease. So your patients, those who are not having visceral metastasis, they have more propensity to respond to TDXD compared to a patient with visceral mets. Next slide, please. Next slide. So this is about the safety data. I think the primary slides that I wanted to highlight about the PFS difference in terms of HER2 low and ultra low, they were not there. But again, there is no surprise to this thing that this is a kind of population which behaves differently. HER2 0, HER2 plus 1, and HER2 plus 2. That is why, in terms of our knowledge, we need to ask to the pathologist and communicate to them that these are the lines of therapy they have received, particularly when you are discussing a case of a hormone positive disease, a patient who has exhausted his endocrine treatment options. Now, if you look at the overall safety summary, I think no surprises there. As we have learned from our earlier experience with the TDXT, there are two different side effects which need to be highlighted. One is the pneumonitis part, which was again way high, and you need to be cautious about your patients, those who are being treated on TDXD. Be very careful about the symptoms and be very aggressive uh, in doing the investigations while assessing them for interstitial lung disease. So the difference in terms of peripheral neuropathy and in terms of pneumonitis was there. Next slide. So in the interest of time, I will highlight only two different side effects. Next slide, please. So these are some of the side effects that one needs to take care. That is the nausea part. Why? Because it is considered as a highly immutogenic ADC based therapy, where majority of the patients, around 50% of the patients, will have some sort of nausea, and this can be adequately taken care with the usage of three drugs, that is NK1 antagonist, 5-HT3 antagonist, and steroids. So this is a highly emetogenic ADC-based therapy as per NCCN, and you need to put your patients with a highly effective anti-emetic agent constituting of three different agents to protect them from the nausea and vomiting part. Rest of the things, fatigability, other side effects, they were there, but they were not so prominent. Next slide, please. So this is about the side effects of special interest that I was talking about. One was the interstitial lung disease, and other is the left ventricular decline in the left ventricular ejection fraction. But if you go beyond grade 3, grade 4, or grade 5, the difference is stark. Although some of the patients will have grade 1 or grade 2, but if they have symptoms, please stop the drug. Please take them to the challenge of corticosteroids and supportive treatment till they return to baseline as grade 0, and then take forward with challenging of TDXD. But if at any given point of time they have grade 3 or beyond side effects with pneumonitis and interstitial pneumonitis, then please discontinue the drugs and choose other modalities of treatment. Next slide, please. Next slide, please. So the quality of life difference was not there. In fact, it was better if you see the physician choice of chemotherapy versus the TDXD based therapy, where the overall health and the quality of life was maintained. Next slide, please. So these are the conclusions with the TDXD. It provides a statistically significant, clinically meaningful PFS benefit, particularly in the setting where patient has exhausted their hormonal treatment options to the tune of 13.2 versus 8.1. Important to highlight in the ITT population also, HER2 plus, HER2 low with HER2 ultra low, the difference is stark. They are almost reflecting what we have seen with HER2 low population. The response rates, if you see the difference in the response rate, this another slide was missing, that the response rate with TDXD versus if you need a response to treatment with a patient who has a high burden of disease with more than 3 metastatic sites, then this is the drug to go, because 60% of the patients will have a demonstrable overall response compared to the physician choice of therapy. No new safety signals were identified, but again, I want to reiterate, I have few patients on TDXD where one of the patient developed interstitial pneumonitis, but it was again grade 1. So with steroids, they resolved to baseline. So again, very important to highlight the onset of symptoms like cough, fever, breathlessness. So definitely do aggressive scanning for these patients to look for ILD and related changes, and then take it forward. So TDXD has been established as a new treatment option in HR positive, HER2 low MBCs following more than one endocrine based therapy. Thank you.
Thank you, Sandeep sir, for in this presenting this and how to in this HER2 low or ultra low metastatic breast cancer. I mean, so few of the points which Sandeep sir has already highlighted. I mean, which needs to be stressed upon is regarding the HER2 testing. So, generally, what we have seen that if somebody has got a fish HER2 negative, we categorically label it as a HER2 negative, and we hardly look upon it. But then one has to remember that even if somebody is fish negative, we have to look for IHC, and if IHC is 1 plus or 2 plus, still can consider the use of NR2. And then another important point here I want to highlight is that NCCN mentioned that if somebody has got a HER2 positive and her basic histopathology is showing that it's a grade 1 tumor, it's a pure mucinous, it's a pure tubular or a pure cribriform. Here you're supposed to repeat the HER2 because all those histopathologies, there is a very less possibility that they can be HER2 positive. So there's a so, I mean, those histopathology which I pointed out, they are supposed to be HER2 negative. And then third important point, which sir already pointed out, that one has to be in a good communication with the pathologist. I mean, because he or she is to be, I mean, fully explained that what we are looking for, and a patient has been already treated heavily, and even just HER2 low positivity, I mean, that can be a good news for the patient. So moving on to the next topic, so which I will be taking up. Uh, I hope my slides are visible.
Yes, sir.
So as we are well aware, I mean, time tested, this drug is the trastuzumab, which has been used in this HER2 positive breast cancer. And it will be, I mean, this talk will be, this webinar will be incomplete if we don't talk about it. So as we are well aware that HER2 disease is in itself an aggressive subtype, and most of the time we have seen they relapse early, and moreover they have got a visceral involvement, and predominantly we get to see more of a brain mets. And then if we don't treat them with the anti-HER2 agents, yes, they have got a very short DFS and overall survival. So moving on to the next slide, as you can see that if we see, this data is from the MD Anderson Cancer Center, and what they have seen that over a period of around this uh, 12 years, what they have seen that those patients who are not treated by anti-HER2 agents, they have categorically shown that the disease-free survival was definitely inferior in comparison to those who had HER2 negative. So even if we club all the breast cancer subtypes that like luminal A, B, or basal or HER2 among it, if we don't treat them with the anti-HER2 agents, the prognosis is the worst. So starting with a general case, as we have a patient that who has a 61-year-old patient who has underwent upfront lumpectomy, and besides that, sentinel lymph node pathology showed invasive cancer. It was T2 and 0 and 0. And ER HER2 was triple positive, and HER2 was found to be 3 plus by IHC. So if we look at the NCCN guidelines, what they say that yes, those tumors who are of more than 1 centimeter, we are supposed to treat them with just chemotherapy and trastuzumab, and along with that, endocrine therapy. So the evidence for that is we have a multiple trials in the form of like HERA, NCCTG, or BCIRG everywhere. I mean, as you can see, the disease-free survival benefit has been shown to be somewhere around 6 to 12% with the addition of a trastuzumab, and moreover, that has also translated in terms of a overall survival also. So, what are the risk factors for recurrence of those early breast cancer, those who have been treated with trastuzumab alone? And after doing this univariable, multivariable this analysis, what they have found that it was primarily T stage, and then besides that, the nodal positivity, and then the third important point was the hormone receptor status. So, adjuvant therapy, patient with lower risk HER2 positive early breast cancer, yes, we are supposed to treat them with this chemotherapy plus trastuzumab, and the evidence for that is earliest trial was that of APT trial, in which they took all those patients who had a early disease. Early disease means those who had a less than 3 centimeter disease and they had a node negative disease. So they treated them with this chemotherapy or chemotherapy plus trastuzumab, and trastuzumab was completed up to complete 1 year. So as you can see, the disease-free survival, I mean, it was quite good. 3-year DFS was around 98.5%, and then if we 7-year DFS, it was somewhere around 93.3%. But then if we just them stratify with hormone receptor positive versus negative, as you can see, the hormone receptor positive did slightly better. Now, there was an attempt to improve beyond trastuzumab in an adjuvant setting in all those early HER2 positive breast cancer patients. As you can see, they tried to just introduce chemotherapy altogether, chemotherapy-free regimen. That was by the introduction of a TDM1, and another arm continued with a conventional paclitaxel plus trastuzumab. So follow-up was after 5 years of final dose of TDM1 or trastuzumab paclitaxel. So as you can see, in the APT and attempt arm, in both of the arms, as you can see, paclitaxel trastuzumab produced 3-year DFS of around more than 90%. It was 92% in this attempt arm and 98.5% in the APT arm. But with this introduction of this trastuzumab, this amtensin TDM1, this also led to the 3-year DFS was somewhere around 97 or 98%. But then most important point was regarding the safety. So overall, if we see the toxicity wise, TDM was definitely, I mean, this worse in comparison to the trastuzumab paclitaxel, and moreover, attempt it didn't meet primary endpoint of a 40% relative reduction in toxicity with TDM1. So this was all about the early HER2 positive breast cancer. What about those who have got a higher risk HER2 positive early breast cancer? So again, the patient who has been upfront operated, that 44-year-old and who has undergone bilateral mastectomy with axillary node dissection, and tumor was found to be a 5.4 centimeter. 6 out of 11 nodes were found to be positive, and again she was having a triple positive disease. So here, the noteworthy point here is that as per the NCCN guidelines, as you can see here, they have mentioned clearly as a category 1 recommendation for those who have got a node positive disease and those who have been operated upfront, that here the pertuzumab is to be added to the existing trastuzumab and endocrine therapy regimen. So for that, we have evidence already in the form of a affinity trial, I mean, which has clearly shown, and now we have a very mature data for this 10-year. And here, as you can see, that invasive disease-free survival was definitely better with the addition of a pertuzumab, but this was applicable to those patients who have got a node-positive disease, not to those who have got a node-negative disease. So this is really very important in our scenario, because every time we don't get to see a HER2 positive patient who has been seen by a medical oncologist and who will treat her with a neoadjuvant chemo. There are patients who are upfront operated in spite of having HER2 positive, node positive disease by general surgeon. So I mean, here we can use those guidelines or those recommendations to treat that patient. Now, what about improving beyond this? I mean, giving this trastuzumab, pertuzumab. What about extended adjuvant therapy? So again, we can take a background of a similar patient that patient was treated with adjuvant chemo, trastuzumab, pertuzumab, and endocrine therapy. Here we have a NCCN guidelines which they have mentioned that yes, beyond this pertuzumab, trastuzumab, hormone therapy, you can even consider using adjuvant neratinib. So, I mean, this adjuvant usage of a neratinib has been particularly proven to be of benefit in those who have a hormone receptor positive, HER2 positive disease. But then one thing that has to be noted down is that the benefit or toxicity associated with extended neratinib in patients who have received pertuzumab is unknown. But biggest problem with the usage of a neratinib is the diarrhea. I mean, the antidiarrheal prophylaxis is to be almost started in almost more than 50% of the patients. So with this, I mean, that drug has really taken a back seat, and majority of the, I mean, physicians have felt a bit of a reluctance in using that. So this is the data for that XTNet 5-year update, neratinib versus placebo after adjuvant trastuzumab in HER2 positive early breast cancer. So primary endpoint they took was invasive disease-free survival at 2 years. So as you can see, there's a difference of around 3% invasive disease-free survival. But then when we see it in doing risk this stratification in terms of a hormone receptor positivity, was more beneficial in hormone receptor positive disease. That is, there was an improvement of around 4%, while in hormone receptor negative disease, it didn't made any big difference. So moreover, if we see the hormone receptor positive and less than 1 year from the last dose of trastuzumab, again, the difference was 5%. But if this hormone receptor positivity and less than 1 year from the last dose of trastuzumab without PAC-CR after neoadjuvant treatment, the benefit was bit more pronounced, that is 7.4%. So we can say with confidence that yes, somebody who has a this triple positive disease and node positive disease, and he or she has been treated with this pertuzumab, trastuzumab, yes, we can improve beyond it with the addition of a this neratinib. Now, coming on to the neoadjuvant therapy, as already has been said about it by Dr. Burhan. So here we can take a patient who was a 33-year-old, and here again she had a triple positive disease, and uh, so now the question arises: who are the patients who are supposed to receive this neoadjuvant chemo? So neoadjuvant chemo are any patient who has got a tumor of a more than 2 centimeter, or any patient who has got a node positive disease. So regardless of the hormone receptor status, should receive neoadjuvant chemo with a this trastuzumab, pertuzumab with chemotherapy. So for that, we have this evidence, and that has been already said by Dr. Burhan, like Neosphere study and Trifina study. Now, as I already put the question to Dr. Burhan, that I mean, where does he places the usage of anthracycline in the era of this dual anti-HER2 in a neoadjuvant setting? So here we have evidence for that in the form of a phase 3 train 2 study. As you can see, they here tried to give this just TCHP, or another arm they gave FEC also. And then what they observed, that the primary endpoint they took was pathological complete response. I mean, pathological complete response was almost similar in both of the arms, and moreover, it was consistent across all the pre-specified subgroups, whether you talk about the T stage or a nodal positivity or a hormone receptor positivity or age. So, moreover, there was no statistically significant difference in event-free survival with or without anthracyclines. So, what about post neoadjuvant therapy? So, again, as I mean, already has been said by this Dr. Burhan, that somebody who has been exposed to this pertuzumab, docetaxel, trastuzumab in neoadjuvant setting, and after that, residual disease is present. Yes, we are supposed to use TDM1 alone for 14 cycles, because for that we have evidence in the form of a Catherine study. So we can say clearly for the time being that guidelines are quite clear. If patient has got a very early disease, that is T1A or B, you can subject the patient straight away to surgery and give in adjuvant setting this paclitaxel, trastuzumab only, and complete trastuzumab for complete 1 year. But beyond it, I mean T1C, if patient has got a this high risk, they took all those patients who have got an age of less than 3 years, or a grade 3, or a hormone receptor negative, or a multifocal disease. So they are supposed to receive neoadjuvant. Otherwise, you can also take the patient for upfront surgery. But beyond it, the guidelines are quite clear. Yes, take for a neoadjuvant chemo, and then see for a residual disease. If present, go for TDM1. If PAC-CR, you can carry on with the this pertuzumab, trastuzumab. Now, overall, if we sum up the whole of the early breast cancer, I mean, HER2 positive disease, trials have been carried out to escalate as well as de-escalate. I mean, escalation was in the form of, yes, no PCR, go for a TDM1. Besides that, even bevacizumab has been tried, which has been found to be a negative trial, and then neratinib, it has been found to be positive trial, but yes, at the cost of a toxicity. And then other than that, positive trial was in the form of affinity, and then moreover, even trastuzumab duration has also been attempted to be of 2 years. That was of HERA study, but again, it was a negative trial. And then other than that, de-escalation was attempted in the form of, like, I mean, anthracycline free regimen, and that has been proven to be equally beneficial. And then other than that, even chemotherapy free regimen has also been tried, like ATEM, that was a negative trial. Moreover, important point was even reducing the duration of adjuvant trastuzumab has also been tried, and it's not one or two. I mean, there are 5 trials. But if we see out of 5, I mean, 4 trials have got results, and out of those 4, only one has supported, which has been proven to be of non-inferior for the usage of a 6 months. But otherwise, the rest of the 3, they have been considered as a negative trial only. So besides that, I mean, this was all regarding the early breast cancer in this, and Now, what about the trastuzumab in a metastatic HER2 positive? Yes, we have early trials like HO648G or M77001 or tandem study. As you can see, they try to stratify those patients who have previously received anthracyclines, yes or anthracycline exposed or not, and what they gave in chemotherapy arm like adriamycin cyclophosphamide or paclitaxel. So what they have shown that clearly, yes, it has been proven to be to work in even in a metastatic setting after the addition of to chemotherapy, and we are well aware. I mean, we are to see in daily our practice, and even complete responses have also been seen. So similar was the case with overall survival. Now coming on to the cardiotoxicity, as expected, I mean, addition of a trastuzumab to anthracycline regimen has been found to be associated with a high cardiac toxicity. Now, then besides that, other than that, we have another M7001 study. Again, here they gave only docetaxel, and another arm they gave docetaxel plus trastuzumab. Again, as you can see clearly, addition of a trastuzumab has remarkably benefited the patients. Now, other than that, there was another study, tandem study. Tandem study was mainly carried with an intention, as we know that there is evidence of a crosstalk between the HER2 and the estrogen receptor signaling pathway. So study was taken particularly those who have got a triple positive metastatic breast cancer. So what they have shown that in one of the arm they just gave anastrozole, another arm they gave anastrozole plus trastuzumab. So see, this regimen can be of a good use in particularly in all those elderly patients. So as you can see, with the addition of a trastuzumab to anastrozole, there was almost a doubling of a median PFS. And similar was the case with the OS, although not that pronounced in terms of a, PFS, but yes, there was a difference. It was around 5 months over this anastrozole alone. And then moreover, clinical benefit was found to be in almost all of the patients. Then yes, there was a safety profile. I mean, there were cardiac side effects more in the trastuzumab arm. So we can say that yes, in any metastatic HER2 positive breast cancer, trastuzumab holds a cornerstone. And in presently, as already has been said about that, yes, we are supposed to combine trastuzumab with the pertuzumab in upfront setting, and then beyond it, we have multiple options. So with this, I conclude my talk. Thank you. So moving on to the next talk. If you have any questions, we can take up, or we move to the next talk. So our next speaker is Dr. Jagmohan, who is working as a consultant radiation oncology in American Oncology Institute, Jammu, and who will just enlighten us regarding the role of adjuvant RT in breast cancer, in particularly low nodal positive disease. As we are well aware, more than N3, whenever we get to see, we are clear, okay, that patient is to be exposed to radiotherapy. But whenever we get to see N1 to N3, that is sort of a gray zone. I mean, we are not very clear what to do. So he will try to, just enlighten us regarding that. So over to Dr. Jagmohan, please.
Good evening, Dr. Nadeem. And it's a very nice presentation, and thanks for giving me this opportunity. Please, my slides. Hi, am I audible?
Yes, you are very much audible.
Okay, thank you. So my topic is the role of adjuvant radiotherapy in breast cancer in low nodal disease. Breast cancer epidemiology, as we all know, the breast cancer is the most common malignancy among the women worldwide. It's increasing, that rising incident in India, particularly in urban areas. And if we see the 5-year survival rates improve due to the recent new modalities, multimodalities treatment. And due to this, the local regional control crucial for long-term survival. Next. This is an overview of staging by AGC TNM staging. Now we are talking about the early stage. The early stages we are taking only T1 and T2, N0, N1, M0. Now come to the low nodal burden. So 1 to 3 axillary nodes and one disease. So it's very crucial to determine the treatment intent and the extent. By the definition, and what is the significance of low nodal disease? If we talk about the typically 1 to 3 involved axillary lymph nodes, which including the low nodal disease, it's present the intermediate risk for loco-regional recurrence and heterogeneous group requiring the personalized treatment. And if for the talking about the management, it will remain a controversial in the RT context. We will discuss further. So, what's the goal of adjuvant therapy? The adjuvant therapy, in any sense, the major goal is to eliminate the microscopic residual disease and decrease the risk of local, regional, and distance recurrence, improve the disease-free survival and overall survival, and also the minimize the toxicity through tailored approaches. So, what types of radiotherapy in the breast cancer? If we go through the literature, the whole blood radiation is the standard after BCS. Chest wall irradiation after post mastectomy, regional node irradiation target the axillary, supraclavicular, intramammary nodes, that regional nodes, and the tumor bed, boost RT to the tumor bed when indicated. The mechanism and the timing of the radiotherapy, as all of you know, the RT causes the irreparable DNA damage in the tumor cells. Most effective in rapidly dividing cells, typically initiated within 4 to 8 weeks post surgery or chemotherapy. Fractionation schedules evolving. We are more moving to the hypofractionation, but in some cases we with the conventional fractionation also to see the toxicity and other profiles of the patient. Now we come to the this early times. There's a trials NSAB B04 and B06 clearly demonstrate the benefit of radiotherapy in local control. Lack modern systemic therapy at that era. We are lagging behind that time. The focus more on the mastectomy at that time versus the lumpectomy plus RT. Still relevant for understanding the baseline efficacy, but due to this modern systemic therapy, we will further beyond the outcome and other things also. So modern understanding of low nodal burden. It improved the systemic therapy, reduce the recurrence risk. Low nodal burden may not require the aggressive regional nodal irradiation in all of the patient who require this. Focus totally shifting to biology-based decision, not on the grades and other things. RT omission in selected patient under evaluation. So NSAB B04 and B06 trials, B04 demonstrate the mastectomy alone versus RT showed the reduced local recurrence with RT, and B06 show the lumpectomy plus RT versus mastectomy show the equivalent survival. Established RT as the standard post lumpectomy due to this low regional recurrence in these trials, but did not certify the based on the modern nodal classification. And both the trials which don't show any overall survival benefit, but clearly show the reduced local regional recurrence. EBC TCG meta-analysis which show this trials, it included more than 8,000 women with 1 to 3 positive nodes. Post mastectomy RT reduced the recurrence by 15%, and that breast cancer mortality reduced by 8.1%. Benefit that independence of age and systemic therapy. MA20 trial, which is a randomized trial, it included 1,832 women to whole breast radiation plus this regional nodal radiation. It will improve the DFS 90.7 versus 84% at 10 years, 10 years with the regional nodal irradiation. Now 10 towards the improved overall survival. It shows the more benefits ERN negative and younger patient. EORTC 2292 versus 10929 trial, it's include 4,000 patients with central and median tumor or node positive disease. Internal memory and median supraclavicular RT improves the DFS. And more than 50-year results show the reduced breast cancer mortality, highlighted benefit in selected with the low nodal burden patients. There are ongoing meta-analyses which we further acknowledge. EBC-TCG continues the evaluating the long-term survival benefits, its impact on modern chemo, trastuzumab being analyzed. We recently just heard about all these trials. Now, what is the aim? Aims to personalize the RT recommendation result to guide the further future guidelines. Next. Is RT, now my question is RT always needed in a low nodal burden? So RT may be omitted in a selected cases with favorable biology. Older patient with hormone receptor positive tumors, patient receiving endocrine therapy and systemic chemo. That's all about the shared decision making the essential to benefit the patient. Risk stratification in decision making. Yes, the factors which make us wiser, like age, tumor size, grade, margin, status, lymphovascular invasion, and extracapillary extension, that will guide us for the RT needed or not. Nodal ratio, burden impact, this RT needs. Comprehensive assessment is needed for all these things. The impact of modern systemic therapy, taxanes, anthracycline, trastuzumab, improve the systemic control. Now we have come to the pertuzumab and other things. And there's so many things which modally which increase the survivals. But this lower the local regional recurrence risk may reduce the marginal benefit from the RT, especially relevant in the low nodal burdens. The role of tumor biology and genomic profiling, these are the emerging things. The genomic test, Oncotype DX, MammaPrint, will also help the risk stratification. There is ongoing trials evaluating the RT omission in the low genomic risk patients. There are trials that tailor RT based on biology, not just on the node count. They also depend on the biology of the patient. So de-escalation strategies gaining ground on these things. Radiation fields in low burden, it's a standard tangential. We cover level 1 and 2 nodes. If there's dissected axilla, we don't go for to treat the level 1 or level 2. If we don't see any surgical changes in at level 2, we can treat the level 2 also. Regional nodal radiation include the supraclavicle internal memory nodes. The contouring based on astro and astro sensitive balance target, volume and toxicity. We see the toxicity, we go for beyond the level 2 if it's dissected. There's fractionations in adjuvant RT, 40 grain 15 fraction or 42.5 grain 16 fraction is standard in early breast cancer and also safe in 1 to 3 positive nodes. Supported by START and fast forward trials, they improve the compliance and reduce the burden and reduce the toxicity. There are a number of fractionation regimes. It depends upon the patient and other factors. Toxicity consideration in RT is very important. We see the most important acute dermatitis, fatigue, pain, and if we talk about the late toxicities, it's cardiac toxicities, especially left-sided breast cancer, lung fibrosis, lymphedema. So we need advanced planning that reduce the adverse effect. Now we have more techniques to reduce the toxicity in left-side breast cancer, to reduce the dose to the heart, lung, and skin also. So this benefit ratio vitals in low nodal burden. Advanced techniques in radiotherapy, we use IMRT that will definitely reduce the hot spots and improve the cosmosis. The hot spot means there is a more dose within our field, not outside that field. DIBH reduce the cardiac dose, especially in left side tumor. We see the histograms to see the toxicity to the particular organ. So there are proton therapies for extreme sparing in select cases, but it's very costly. And but there are centers they are using proton therapy to minimize the toxicity. So daily IJT improving the precision to reduce the toxicity to the particular organ. There are NCCC guidelines. We see the regional nodal irradiation recommended for 1 to 3 positive nodes with high risk features. Omission of RT considered in select low risk, very low risk cases. And all these emphasizes individual treatment planning and institutional protocol. We need the multidisciplinary input for all these cases is very crucial. There are ASTRO guidelines, the acknowledged role of tumor biology and that comorbidity. Support the RT omission in select cases with low recurrence rates. We also recommend the shared decision making, encourage use of modern planning technique that reduce the toxicity and which increase that the planning and dose to the particular organ or cavity. ASCO and ESMO recommendation, we show the emphasized role of genomic assay for decision making. We highlight the de-escalation trials and personalization. RT indicated in a node positive unless strong reason for omission. Their international consensus shifting to the selective use as we are omitting the RT in low nodal disease or low risk factors. Real world practice variability, RNA use varies by institution, regions, and clinician. Underusing resources with limited settings if we don't have the IMRT or other thing. overuse possible without dissatisfaction. Call for more uniform protocols and awareness to educate that using the higher techniques will reduce the toxicity to the lung and this heart, mostly in left leg page. Now there are ongoing trials, that Supremo trials. It is a randomized trial for the chest wall RT in the intermittent risk patient, which includes T1, T2, and N1 tumor post mastectomy. Is awaiting results to confirm the benefit in low nodal levels, but 10-year that data shows that there is reduced local regional recurrence. But overall survival is still ongoing trial, may influence the future guidelines. One more trial is Taylor RT trial, which evaluate the omission of RNA in patient with low oncotype DX score. So it's very important that oncotype DX score will also guide us for further treatment. ER positive, HER2 negative, and 1 to 3 nodes tumor will omit on this patient of our RT. There is ongoing trial aims to tailor RT based on the genomic risk. Result expected to inform de-escalation strategies for further treatment. Future of personalized radiotherapy. The incorporation of genomics, imaging, AI in decision making is our future. De-escalation trial gaining traction. We got the data. We get the data about this. There are biomarkers. Even patient-centered approach is very important to for the treatment and better outcome. Now we'll focus on maximizing the benefit and minimizing the harm. So summary to the key point is RT reduce the locoregional recurrence in low nodal disease, benefit influenced by tumor biology and systemic therapy. Regional nodal radiation is beneficial in selected high risk cases. The personalization and patient involvement is essential for all the decision making. So these are the references. Thank you for your attention. And open for the question.
Thank you, Dr. Jagmohan, for your wonderful presentation. So just one question to you from my side, that I mean, routinely, whenever we get to see a patient who has underwent a BCS, so we ask the patient, okay, go for a radiotherapy. So, I mean, do you think, I mean, there is a patient who has undergone BCS and she or he is not to be given this RT?
Yes, sir. We can omit in BCS patient also if there is a low risk patient and his age is more than 70 and that T is T1 less than T1. We can omit this RT on this.
So that, I mean, that means besides this ERPR HER2, yes, histopathology has a very, I mean,
yes,
it's a
exactly. Great.
cornerstone in deciding the treatment.
And most important is grade.
Grade, yes. We
Yes.
most of the time we get to oversee the grade and we just straight away just look at the T size as well as the N and then look at the ERPR HER2 and decide about the treatment part.
Yes, exactly,
But yes,
exactly. So grade is very important to decide the further course of treatment.
thank you. So thank you for the wonderful talk. So moving on to the next talk, we have with us now the next talk is by Dr. Avinash, who is working as a surgical oncologist in American Oncology Institute, Jammu, and who will be talking regarding the oncoplasty. I mean, which is altogether a new concept which has come up in the surgical management of a breast cancer has come up, and he himself is practicing it. And so over to Dr. Avinash, just make us wiser regarding that.
So good evening, all of you. Thank you, sir, for the invitation and having me to speak on this topic of from BCS to oncoplasty. So, am I my screen is visible?
Yes, absolutely. Make it PowerPoint mode.
Okay.
Yes.
So I'll be
that's
speaking
fine.
on. I'll be speaking today on the topic of BCS to oncoplastic breast surgery. So, as we know, the breast cancer is a major public health problem globally, with it being the most common cancer in females in India and worldwide. And there has been significant advances in the multimodality management of the breast cancer, and which has led to the overall improvement in outcomes, not only in the overall survival but also in the quality of life. So, breast surgery as a field, as a subspecialty, it has been rapidly evolving for last few years, and there has been a paradigm shift in the surgical approach of the breast cancer surgery. So these are the major timelines of the major landmarks breast surgeries So towards the end of 19th century, the radical mastectomy by Halsted, it came, and it involved the removal of major pectoral muscles and all the nodes up to the level 3. So up about for 30 years to 30 to 40 years, it remained the standard of care until the de-escalation in the form of modified radical mastectomy was done. Then again, slight de-escalation in the form of extended radical mastectomy, because some of the authors, they believe that internal memory lymph nodes need to be addressed by surgery. Then in 1980s, the breast reconstruction was started, and in the same decade, breast conservation surgery was also started. So again in 1990s, sentinel node biopsy for de-escalation of axillary treatment. Then in 2000s, risk reduction surgery, risk reduction bilateral mastectomies for hereditary breast cancers or BRCA carriers. Then in 2005, oncoplastic breast surgery, it came into being. So there has been a paradigm shift in the surgical approach of breast cancer from era of mutilating surgery where major endpoint was survival. We have moved on to the era of organ conservation and multimodality management, where the current focus is the optimization and de-escalation, and quality of life and cosmetic outcome have become more important than as before. And bottom line is always not to compromise the oncological safety of the breast surgery. So when it comes to the organ conservation in modern surgical oncology, so breast cancer is a great success story, and it has served as a role model for other organs also. So what have we learned from the breast cancer story? That big surgery does not always translate into the greater cure. So when it came to the de-escalation of the surgeries, so BCS was compared to the mastectomy in these 6 trials, and there was no ambiguity left after these trials that overall survival in BCS arm and mastectomy arm was equal, but the loco-regional recurrence were higher in the BCS arm as compared to the mastectomy arms. So coming to the studies which were evaluating the cosmesis and quality of life. So there are 3 studies. First of the studies which evaluated the BCS versus mastectomy in terms of cosmesis. The BCS group reported better body image, physical and role functioning, and sexual activity at the 1-year follow-up, and by 5-year follow-up, these results were consistent. Again, a study, clinical determinant study in Germany in 2022. In this study, the BCS patients scored higher in the higher points than mastectomy in terms of body image over mastectomy. Then, does the quality of life and cosmesis just improve with the BCS? So this is one of the older images where BCS has been done, and there was a lower pole tumor. BCS has been done, and this has resulted in a typical deformity which is known as bird beak deformity. So this is the modern day surgery of oncoplasty, where scar is hidden virtually in the inframammary crease and it is virtually not visible. So quality of life does not just improve with the poor BCS, but with a good quality surgery. So are our patients are really aware about the choices for cosmesis? So this was evaluated in a survey in TMH Mumbai. 112 of these patients who had undergone DCS, about 82% of them were really happy with the long-term outcome. So major reasons were asymmetry, retraction, volume changes in the breast. So was there a need for something beyond BCS? So answer is really forthcoming, and it is the oncoplasty. So before undertaking the oncoplasty, there is need for understanding the cosmesis of an ideal breast. So this was a French study which reported the findings of an ideal breast. So upper pole to lower pole ratio should be 45 to 55. Nipple angulation should be 20-degree upward from the nipple meridian. The upper pole should be linear or slightly concave, and lower pole should be convex always. So what do you really mean by oncoplastic breast surgery? So originally, when the term was used in 1980s, it referred to the integration of chemotherapy and RT blinding to the conservative breast surgery. Current definition, it is still evolving, but it includes 3 components to it. First is the aesthetic approach to ablative surgery. Second is the reconstruction of post-BCS defects. And third is the contralateral breast symmetrization procedures. So what oncoplasty really aims to achieve? So according to the Milanese Consensus Conference on Breast Conservation, there are 2-fold aims of oncoplastic breast surgery. So first is the oncological aim to achieve a good voluminous excision and clear margin even in larger tumors. And second is the cosmetic aim to achieve a good cosmesis in patients who would have otherwise achieved an unacceptable outcome with the routine BCS technique. So how does this oncoplasty differs from breast conservation? So breast conservation is just a lumpectomy or a partial mastectomy. It just focuses on the tumor removal without any reshaping of the breast. But on the other hand, the oncoplasty, it integrates the oncological surgery with plastic surgery, so to achieve to both the cancer removal and aesthetic results. BCS, it is suitable for smaller tumors, and oncoplasty can also manage larger tumors. So what are the perioperative considerations? So informed consent is very important, and counseling regarding the risks of bleeding, infection, asymmetry, loss of sensation, fat necrosis, delayed healing should be explained to the patient. Always take photographs preoperatively because patient may not recognize pre-existing asymmetries and patient may sometimes attribute this to the surgery. So photography should be always integrated to the routine preoperative assessment. So preoperative planning, so skin marking should be done in the sitting position for both breasts, and all the relevant landmarks should be identified and marked. So these relevant landmarks are footprint of the breast, which include the inframammary crease, anterior axillary fold, posterior axillary fold, external border of the breast, superior border, and some vice pattern landmarks. So what are the elements for the selection of oncoplasty procedure? First is the excision volume, then tumor location, breast size and doses, and glandular density. So excision volume, so more than 20% of the breast volume when excised, it risks a clear deformity on the breast. On an average, in terms of weight, if 20 to 40 gram of tissue in small size breast and 80 gram of tissue in medium size breast, it can be removed without deformity. And in these cases, simple glandular approximation techniques, that is level 1 oncoplasty, it suffices. Level 2 oncoplasty, it allows larger volume to be excised without risking the deformity in the breast. So there are few zones which are favorable for oncoplasty or BCS, and there are few zones which are unfavorable. So favorable zones are upper outer quadrant, because the good breast volume is available for reapproximation, scars can be hidden in the axilla, and there is minimal distortion of the mound of the breast. So so zones which are at high risk of deformity are their unforgiving zones. They are lower pole because it results in a bird beak deformity if not treated accurately, and upper inner quadrant because it is a social crease or the cleavage site, and also the lesser breast tissues available for reshaping the breast. So this is the glandular density. The radiologists, they usually classify breast density into 4 level density scale. First is the entirely fatty, then the scattered, then heterogeneously dense or extremely dense, which is found in young breasts. So what is the implication of a glandular density? So dense breasts, that is ACR 3 and 4 stage, there can be easily mobilized with a dual plane mobilization without causing a risk of fat necrosis. But the low density breasts, they have higher risk of fat necrosis after undermining the breasts. So coming to the breast size and ptosis, so according to breast size, the classification is done into the type 1, 2, and 3, and for sub-classifications, the defects are further divided into small, moderate, and large defects. So when there are large and ptotic breasts, and you have not done the contralateral symmetrization procedure, so asymmetry of the breast looks something like this, and the patient really goes home unsatisfied because you may have done very good job on the ipsilateral size, but there is a glaring asymmetry. So coming to the classification of the oncoplastic breast procedures, so this is a landmark paper by Krishna Claw, and anyone attempting to start the oncoplasty should always read this paper. So this is a bi-level classification. It divides into 2 levels, level 1 and level 2. If less than 20% of the breast volume is removed, it is corrected by level 1, and 20 to 50% it is corrected by level 2. In level 1, there is no requirement of skin excision, while in level 2, skin excision are usually required. Then mammoplasty is not done in level 1, but it is done in level 2. So coming to the consensus definition by American Society of Breast Surgeons, so this society divided the oncoplasty procedures into 2, that is volume displacement and volume replacement procedures. So volume displacement are level 1 and 2 oncoplasty, and volume replacements are implant based or flap reconstructions. So what is the level 1 oncoplasty? So it is a biplanar dermoglandular mobilization to fill the defects in the breast, and the blood supply is a random pattern because the glandular tissue of the breast has rich anastomotic network. So it has a basic six steps of level 1 oncoplasty. First is the skin incision, then undermining of skin, then nipple areola complex undermining, full thickness excision, glandular reapproximation, and NSC repositioning to allow the correct position of the nipple areola complex. Then level 2 oncoplasty, these are complex procedure and lot more planning is required as compared to level 1 procedures, and they are typically very large volume resections, and rotation of breast tissue is made on a definite or named vascular pedicles. So invariably there is a need for contralateral procedures in level 2 oncoplasty. So these are the algorithms for upper quadrant lesions. If there is an upper quadrant lesion and it is nearing the nipple areola complex with minimal ptosis, crescentic mastopexy, and round block mastopexy is the procedure of choice. If there is a ptosis, battling mastopexy or mammoplasty should be done. Then if the lesion is away from nipple areola complex with minimal ptosis, racket mammoplasty is done, and with ptosis, inferior pedicle mammoplasty is preferred. Then lower quadrant lesions, medial 1/3 of the breast, it can be corrected by a V-shaped mammoplasty. Central third, it has to be corrected by a Weiss mammoplasty, and lateral third by J-shaped mammoplasty. Then about this central quadrant lesions, for lesions who are close to the NSC or NSC is involved, with minimal ptosis, Grisoti flap is the flap of choice, and with ptosis, central lumpectomy should be done. For lesions who are away from the NSC and there is no ptosis, round block or crescentic mastopexy should be done, and for ptosis, Badwing technique is the preferred choice. So these are the few commonly done procedures in the oncoplastic breast surgery. So these are level 1 oncoplastic procedures. So this is a donut mastopexy or round block technique. So this involves the 2 concentric incisions around the areola, and it involves the lifting the breast skin and undermining the skin and going to the tumor, removing the tumor and reapproximation of the tumor. So it closes like the bottom image, and really the scar is not visible after the round block technique. Then the second procedure or Batwing mastopexy, it is done in upper quadrant lesions and where there is a large ptosis. The Batwing mastopexy corrects the ptosis as well as removes the tumor. Then V-shaped mammoplasty, it is usually done for lower inner quadrant lesions, and it also involves the deepithelialization of nipple and inframammary incision, and it closes like a bottom image. Then there is a Grisoti flap. So it is used for central quadrant lesions where nipple areola complex is removed, and the new nipple areola complex is borrowed from the skin along this line as marked in the diagram 2. So this is the racket mammoplasty, and this is usually done for upper outer quadrant lesions where there is a large volume of breast and or 9 o'clock lesions. So these are the level 2 oncoplasty where there is a need for a contralateral reduction procedure also. So this is a superior pedicle or Weiss pattern mammoplasty where there is lesion over the lower pole of the breast, and it also corrects the ptosis and as well as removes the tumor. So this is the opposite of superior pedicle. This is inferior pedicle Weiss pattern reduction mammoplasty, and this is usually done for upper pole tumors. So coming to the volume replacement techniques, so it is suitable for volume loss for greater than 40 to 50%, and it involves the placement of implants or flaps which are named on a named vascular pedicles. So it involves the myocutaneous or fasciocutaneous flaps, which include mini LD flap or thoracoabdominal flaps, then perforator flaps, which include TDAP flap, LTAP flap, LICAP, ICAP, and MICAP flaps. Free flaps, which require a plastic surgeon, are deep inferior epigastric artery perforator flap and superior gluteal artery perforator flap, and also the ALT flaps. So these are the examples of the volume replacement techniques, and this is a mini LD flap, and skin is usually borrowed from the back as shown in the picture 1, and it is used to correct the deformities or a tumor excision in the outer or lower quadrant of the breast. So coming to the perforator breast flaps, so perforator are usually located along the creases of the breast. So inferior mammary crease usually has medial bicap flaps and ICAP flaps, and lateral crease has LICAP and LTAP flaps. So these are the perforator flaps. So ICAP flap is usually done for lower quadrant tumors, and these two limbs of in the first picture, it is used to replace the volume in the defect. So this is the LICAP flap. It is usually done for lateral quadrant tumors, and the skin is usually borrowed from the lateral mammary crease. So coming to the oncological safety, whether oncoplasty is really equivalent to BCS or not. So there is no randomized controlled trial till now. There are retrospective cohort studies and meta-analysis. So this is a retrospective cohort study which compared BCS with the oncoplastic reconstruction, and there was no overall survival difference or recurrence-free survival difference when comparing BCS with oncoplasty. So OPBS on the other hand had lower seroma formation and positive or closed margins compared with the breast conservation surgery. Then this is a meta-analysis which compared the BCS with the oncoplastic techniques, and positive margin was significantly lower in the oncoplastic group. Re-excision was also less common in the oncoplastic group. Local recurrence was also less common in the oncoplastic group, and the satisfaction with the aesthetic outcome was significantly higher in the oncoplastic group compared to the BCS group. So coming to the breast RT after oncoplastic procedures. So as we know, whole breast RT is an integral part after the oncoplasty. So there are really possible concerns among the radiation oncologists after the oncoplastic procedures. So first of all, the tumor bed and margins are not in the same field always because of the extensive tissue rearrangements. Then post-operative scar, it is not a useful, reliable marker for RT planning. Then safety of marking a tumor bed with clips, it is not well established in oncoplasty as with BCS. So this has really led to confusion among the radiation oncologists to delineate the boost volume, which is regarded as a prognostic factor for recurrence, and larger boost volume it adversely affects the cost basis also. So coming to the consensus guidelines, what to do to address these concerns. So surgical clips are always necessary, should be placed around the minimal 4 clips should be placed on in the cavity, plus 1 to 4 clips at the posterior margin if necessary. So operative reports or intra findings should be very detailed and should include all pertinent information to help guide the radiation oncologist. So radiation oncologists should also have a basic understanding of the oncoplastic techniques, and both breast surgeons and radiation oncologists should work on speaking on a common platform or a common language. So careful consideration is always needed when determining boost volume in procedure with extensive tissue arrangement in oncoplasty. So coming to my concluding slides, so OPBS or oncoplasty, it is a well-established surgical option. It contributes to better oncological and cosmetic outcomes. It does not require any specialized equipment and it is feasible in majority of the health setups, but it does require the surgeons with specialized training and skill sets. So key to success in oncoplasty is always the individualized planning for each and every patient, and multidisciplinary collaboration is always must. So thanking you. So that's all.
Thank you, Dr. Avinash, for a wonderful presentation. I mean, altogether a new thing which is to be learned by particularly medical oncologists and then, of course, radiation oncologists also. I mean, now I just have a few other questions. I mean, regarding if a patient has got a nipple areolar area tumor, I mean, if the nipple is also involved. So, how, I mean, and then later you can reconstruct, I mean, do you reconstruct the nipple? Is there any, I mean, way out for that?
Yes, sir, there is the simple, there is a simple way to really construct the nipple areola complex. So it involves the boring the skin from the, as I already shown in the slides also. So it involves the boring skin along the lateral mammary crease. So it transposes the skin paddle of the where the future nipple will be to the future defect. And also a nipple areola can be the nipple can be constructed later on, because really there is a need for radiation after the breast oncoplasty. So nipple may get deformed. So if you really want to construct a nipple, so it should be done after RT. And with regard to areola, so some of the females, they really opt for tattoo artists to create this areola, so as to form the pigment. And nipple we can make later after the radiation completion.
I mean, do you think, I mean, there is any usage of this artificial intelligence, I mean, in breast reconstruction, I mean, images, if can we use that, I mean, in a preoperative setting, so that, I mean, to demonstrate exactly the patient how the breast will look like or something like that?
Yes, the few of the centers in MSKCC and MD Anderson, they are using the breast artificial intelligence models for reconstructing the breast, and they have found it to be really beneficial. And they have created the nomograms for the reduction in the breast volume and what volume you need to achieve from the flaps or any other methods by reshaping the breast. So it is still very early in infancy, but they are still using, and they have found some benefits for the oncoplasty.
So thank you, just Dr. Avinash. So moving on to the next presentation, which will be the panel discussion, which will be taken up, which will be moderated by Dr. Javed, who is working as a consultant medical oncologist in GMC Srinagar. So Dr. Javed is considered one of the big names of medical oncology in Srinagar. So considering his enthusiasm, I think, I mean, we all would definitely enjoy his panel discussion. So over to Dr. Javed, please. So as far as
Assalamualaikum, good
panelists,
evening.
so as far as panelists are concerned, I mean, I can also join if you allow.
Yes, very good. I was about to say that. Thank you, Dr. Nadeem, for giving me opportunity. It was a very well-designed webinar on HER-positive breast carcinoma management. You have discussed all aspects of the early, neoadjuvant, adjuvant, metastatic. So I think the job has been already done. We'll just try to recap what has been discussed in earlier presentations. So our panelist, Dr. Asif, that he is basically consultant from the Prince Ali Khan. What has been given me the information, medical oncologist from Prince Ali Khan, or it's from the Ahmedabad.
Sir, I did medical oncology from Prince Ali Khan, Mumbai, and
Okay.
I'm working as consultant medical oncologist in Ahmedabad.
Okay, have we met somewhere? I feel that we have met.
Sir, we met in one conference with.
Yeah.
Probably
He,
Delhi.
yes, exactly. I got it.
Yeah.
A very enthusiastic young chap. Yes, then we have a Dr. Burhan, our friend, and Dr. Satyankar and Dr. Nadeem is also here. So all are here present. So let me delve into this today's discussion on metastatic breast cancer. My slides are, I think, well seen.
Yes.
So let's go directly to the patient presentation. If we take this patient as a 55-year-old female post-menopausal, at her initial presentation had clinical stage of T2N1. So it will be 2B, and the further investigations that were done, hormone negative and her was positive. So one would, as it has been discussed previously also, in today's webinar, that you would like to give neoadjuvant chemotherapy along with anti-HER2 treatment. So today's the gold standard is neoadjuvant TCHP, that is FASCO with platinum and docetaxel. And post chemotherapy, whether some people say that giving 4 cycles followed by surgery, that my take will be always that to complete full neoadjuvant chemotherapy before going for surgery. And then if you go for surgery and then you see any residual disease, and then your Catherine trial comes into play. If there is a residual disease, you will give adjuvant TDM1. So same was done to this patient. So treated in a real manner, just like in the trial. So then down the line, 2 years after completion of adjuvant therapy, she was okay. Following the medical oncologist, and she presented with cough and backache An X-ray was done that showed bilateral lung nodules, no effusion, and the ALP was raised. So there was a suspicion that possibly there is bone metastasis or the lung metastasis. Dr. Asif, how will you go further about this patient as far as the investigation is concerned? This patient is presenting to you now in metastatic setting, likely metastatic setting.
Yes, sir. So I would like to do PET CT scan first, and after PET CT scan, I would also like to do biopsy of metastatic site to understand that now ER/PR hormone is positive or negative. Because if it is negative, once we need to recheck it if it is converted into positive. So and then plan further treatment.
Fine. You said that I will go for the PET CT and then go for the biopsy. Now her PET CT came as a lung mets and bone mets. Where you will go for the biopsy? Lung biopsy or a bone biopsy?
So I would like to, sir, discuss with international radiologist who is going to do biopsy, and wherever he feels comfortable, I feel it's the right way to do it. But I think if bone is accessible, bone biopsy can be done, and if peripheral area of lung is affected, then CT guided biopsy is quite possible.
Dr. Nadeem, your take on this. Would you like to have lung biopsy only, that you will try to avoid the bone biopsies? As most of the times, the bone biopsies, you don't yield receptor status very well. They say it has decalcified, the tissue is not preserved most of the times.
Absolutely. I mean, yes, bone biopsy, I won't be very enthusiastic regarding, and moreover, if the bone doesn't have a good amount of a soft tissue component. So, and moreover, as Dr. Asif has already pointed out that if we have a peripheral lung lesion, yes, peripheral lung lesion should be preferred rather than a bone. But yes, if a patient has got a very intraparenchymal lesion and it will be difficult, patient can end up in a complication. Yes, bone biopsy will be only then preferred. But otherwise, bone biopsy, I won't be very enthusiastic because most of the time, while doing decalcification, there is a good amount of possibility that you may land up with no tissue.
Exactly. Dr. Buran, how often you see that hormone negative coming as an hormone positive in the recurrence? And do we have any in a literature that availability that what's the percentage of hormone negative to go into hormone positive or hormone positive to go into hormone negative in metastatic setting in
Yeah,
recurrence?
I think as far as the change of the biology is concerned from hormone negative to hormone positive, I think it is the least that we see in the clinical practice. From hormone negative going to hormone positive. Rather, it is the other way around that we often see in our patients. Either they remain the same or they may actually from hormone positive go to hormone negative. So if I see the percentage, exactly, I don't know the data as far as the exact percentage is concerned, but I think it will be from negative to positive, it will be, I think, less than 5% of cases, very least, very rare. It is not that common that we see. But as far as a positive, from positivity to negative, I think it should be significant.
It's around 10 to 15% still. Dr. Satyankar, your take on hormone, this HER positive to HER negative, as this patient, now you have to manage, as Dr. Asif rightly said, we have to do the biopsy to see whether HER is retained or not. So her chance of having the HER negativity.
Again, just about 10 to 15% chance, but largely it would stay the same. The pattern of recurrence being HER2 positive is pretty high as compared to HER2 negative. So this HER turning to negative is very less, very very less.
Absolutely. So we have to go for the investigations. We have to go for the biopsy. That is mandatory. We don't have to rely on the previous biopsy. Maybe 10 to 15% of the times we may have the change in receptor status. Agreed. So this patient had a lung biopsy done, and rightly, it is same biology as it was earlier. So now how to manage? Back to Dr. Nadeem.
Javed, I just have one point before proceeding further. What
Okay.
about doing a liquid biopsy? Suppose you are not able to do any sort of tissue biopsy in this patient. So what about liquid biopsy? Because now this is a new thing that has come up, and I will share an experience. I will share an experience where the patient was negative for her as far as the biopsy was concerned. And I could find one of the mutations in the HER2 receptor or in the liquid biopsy. And after that, I have treated from, she was previously on hormone, she was a metastatic disease. So I treated the patient. It was a learning for me that it can leak from the liquid because there was no solid, we can do a repeat biopsy. So I did a liquid biopsy in those patients just to check out. So what is the biology, but is the anything new mutation? Because I did it for, actually she was on ribociclib plus the fulvestrant, and I checked it for some other things. But to my surprise, I got a mutation in a HER2 receptor. And after that, I
Yes,
had to prove with the. So this was a
yes.
learning to me. I
If
just want to know
yes,
from the panel that how they are actually seeing as far as the liquid biopsy currently in the current era.
if we talk of hormone positive and progressing and with her positive, as you say, let us say triple positive, and patient is having a progression of the disease, then that has a significance, and that there you have a literature that is supporting you. Maybe ASR alpha mutation is coming, PIK3 mutation is coming, and you have to change the line of the treatment as far as the hormone positive is concerned. For her not positive, changing the treatment on liquid biopsy, I think that is not the standard of yet. But things are changing. Maybe it will come up in future. But so far till now, I have not heard of that. We should chase her positive disease on liquid biopsy. Dr. Nadeem.
So
I mean,
my take is about what about doing a liquid biopsy? Suppose if the patient doesn't have positivity, we don't have tissue. Many a times we do have tissue, but we have paucity of tissues at times. Anything to corroborate
Desperate
for the.
situations. You are talking of desperate situations. Yes, desperate situations you can do anything, but standard is no for her positivity. So you have to do biopsy for that purpose. But in desperate situations, patient doesn't want to go for the biopsy, or the disease is there that interventional radiologist says you that no, I cannot do the biopsy. For example, as a cervical, this. Some vertebra there disease there, and patient was HER positive earlier on, you want to see the receptor status. That's very difficult. Nobody will touch that patient. So in those situations you may try. That is a desperate situation, but not standard for HER positive. Dr. Asif, your take.
Sir, thank you for asking this question. But I feel that ERPR and HER2 by IHC is we are seeing protein expression, and we can't see any protein expression in liquid biopsy. Commenting on the situation of HER2 mutation got positive in liquid biopsy, it is HER2 mutation. So if we are
Yes,
saying HER2 amplification, then it means
that won't
something.
be picked up.
No,
Right. So
amplification
only
was not
HER2.
there.
Yeah, so HER2 amplification means HER2 antibodies will be effective. Otherwise, HER2 antibodies will not be effective. We can't give trastuzumab and pertuzumab in HER2 mutated patients. We have to give only TDXD because it is ADC.
Exactly.
Right. So ERPR, we can't do anything with liquid biopsy. So liquid biopsy is there to see genetic alteration rather than protein expression. Protein expressions
Exactly.
can be seen only by IHC.
Point well taken. As I was saying that yes, we have to see ESR alpha mutation, PIK3 mutation, added mutations, which will give you the resistance. So fine, things are changing. Maybe newer things will come. We never know in an oncology. So this patient now it's a metastatic disease. 2 years down the line, she had received this FASCO with chemotherapy in the neoadjuvant setting. Dr. Satyankar, how do you manage this patient? She has bone metastasis and she has lung metastasis, but she is not in visceral crisis.
Yeah, but still disease burden is high, and ERPR are still, I think, negative only. And
Yes,
I
yes.
think she should be treated as per the Cleopatra regimen with
Yes, so
denosumab.
we have to take her as a fresh metastatic patient. So
Yeah.
the standard of fresh metastatic patient is PhD. So this patient again now you have the
I think prior to that, MRI brain will be very important because HER2 positive patients have got a very high preponderance to metastasize to brain. I mean, that is also to be known first. I mean,
that
because
did not show any metabolic hypometabolic activity. Yes, that is not basically for the brain. Uh, but here she was also asymptomatic for the brain. So rightly PET was done. So I think we don't need to do further if patient is asymptomatic, isn't it?
Yes.
So it is not lung that you have, it is mandatory that you have to go for the brain screening unless and until patient is not symptomatic. So you have given PTH, and after this PTH, we know the one somebody has presented this Cleopatra. I think Dr. Burhan, you have presented today Cleopatra,
Yes.
and
Yes.
see there is 8 years data of PFS and OS, and we can see that the PFS from the Herceptin versus PhD is increased by the 6 months. PFS, 12 months to 18 months. And if you look at the overall survival, median overall survival, 40 months versus 57%. So it is good. So it's now the standard of care that we have to go give the same way. So this patient completed 6 cycles of PhD. Then what further? So we have to continue the maintenance till progression. So that will be the aim of everybody to continue the treatment with trastuzumab, pertuzumab as a maintenance. Dr. Asif,
Yes.
if patient develops CR, will you continue
Yes,
dual HER2 or you will just skip one?
yes, sir. I'll continue both in metastatic setting. In only adjuvant setting, there is very little role of pertuzumab. In NSCT, neoadjuvant and in metastatic setting, there is a good role of adding pertuzumab in maintenance also. So I'll continue pertuzumab plus trastuzumab.
So here again we have to add bone protective agents. So now we have two agents here, zoledronate and denosumab. Dr. Burhan, which will you choose among the two? Don't talk of this no cost. There are no cost constraints.
So
Is this
yeah,
is
I think the data as far as the
relative.
yeah, I think the data is quite significant for the denosumab. So I will be
Yeah.
choosing the denosumab in this patient. And most of the times, like if I'm planning FESGO, so that will be a subcute injection, easy to administer for the patient as well. So keeping those into consideration, my choice will be the denosumab.
Exactly, point well taken. One, compliance and the data for denosumab. It has been, recently from the ASH 2024, and was a very good editorial regarding the zoledronate versus denosumab. SREs are decreased once you give denosumab more than that of the zoledronate. I think there's a difference of 15 to 20% at a few years if you give denosumab than zoledronate. So now this patient is in CR and we are continuing trastuzumab, pertuzumab, and we have to continue till progression. So almost 2 years down the line, this patient developed again newer lung metastasis. Dr. Asif, how do you manage now?
Sir, again, if hormone was negative, I will again do rebiopsy to see if it is turning positive or not. If it is still hormone negative, HER2 positive, then I will choose TDXD as next line.
In your real world scenario, do you do still another lung biopsy?
Yes,
Same
sir.
patient is
Uh,
coming to you, you will do it.
yes, sir. If
One
something
is
is
one is
negative,
sinus, one is sinus, one is sinus. I'm not talking of science. I'm talking of just a patient is following you for last 4 years in neoadjuvant,
sir, we
adjuvant.
are talking about this patient progressing after 2 years. So I
Yeah,
think rebiopsy is fine. Matlab, if patient is progressing very fast, 2 3 months or 6 months, then we need to look into it, and we probably will not do rebiopsy. But 2 years is quite good time to change the biology.
very good. Dr. Satyankar, are there takers to get a new second biopsy done? I have
No,
not
no.
seen that anybody, my patient, they will run away. They will change the doctor. They will go to Dr. Nadeem. They will travel 300 kilometers, but they will never come to me.
But Nadeem will also not do rebiopsy.
But if he will tell them biopsy, then they will come to you. But they will never turn to that doctor again. Say he is
I don't
always
think we
asking
do.
for the invasive things. He's an invasive oncologist. So better to leave and go to some oldie and he will say, okay, let us give another regimen. It's very difficult, Dr. Asif. It's very difficult. You have done once biopsy. I'm not saying that decision is not good. Your decision is exactly correct. That 2 years things change. You may have another mutation, you may have receptor status changing, maybe hormone positive is coming, you never know. So in real world scenario, we are not seeing this thing happening, that getting another biopsy to the lung. Nadeem.
But if we look at the, I mean, the molecules which are available as an anti-HER2 agent, I mean, they are so costly. So giving it to someone who is already HER2 negative, I think that doesn't justify. I mean, for that
Very
reason,
good,
we should.
very good. That is the point. That's the point. So we have to convince them that you have to get the biopsy. Otherwise, that TDX, if you give, it will cost around 3 lakhs. Biopsy is not that costly, so it may be
No,
10,
but
15,000.
but TDXT is recommended for IHC 0 also. So what's the point in doing a biopsy?
That is recommended for IC 1 plus, huh? 1 plus, 2
No,
plus.
I
One
think
plus.
0 also, ultra low.
No,
Ultra low.
ultra low was one.
1 plus, 1 plus. That's 1
One
plus.
plus.
Yes. So Dr. Asif is saying that this patient should receive now
And
TDM
HER2.
And
or
T
TDX.
TDXD.
Why
Right.
not TDM? Why not TDM?
Sir, both are ADCs, but TDXD is far better ADC, and it is next generation ADC, and it has very good data of improved overall survival and PFS against TDM1. So I will choose TDXD.
Dr. Buran, there is a catch in this patient? Why not TDM?
So even if it is lung metastasis, I will not fall apart looking at ILD chances for these patients and not give TDXD.
That is not the catch here. Dr.
I think
Burhan, there is a
there is
catch here. Why not TDM?
no brain metastasis as of now.
Dr. Nadeem, there is a
Yeah,
catch here. Very good catch.
I also dropped it.
what you are asking about the
Why not TDM?
why not TDM1?
Mm.
I think one thing that has happened that could be that you might be pointing is that the liver toxicity that might be one of the things that has been reported, but not very high. I personally feel.
So we will discuss that. I will show you why not that. So this patient progressed. So you have to evaluate. You have to do another PET CT, whatever the imaging that's needed. We have to do it. And Dr. Asif said that 2 years is a big time, long time that we have to go for the further biopsy. Absolutely correct. And which treatment options you will recommend? These are the options. So if patient is not having any financial constraints, everyone will like to give TDX, and it has been, and now the NCCN guideline in the second line setting, and is moving ahead of the TDM. But TDM is also option. Lapatinib capecitabine is an also option. But pertuzumab, trastuzumab, she has already taken, so that's not an option. So we have still 1, 2, and 3 options which are left, but TDX is the best. So if you can see that while progressing from first line to second line, 22% of patients don't receive the second line, and 35% patients don't receive the third line. So it is better to give a better drug as early as possible. Otherwise, he will or she won't be a taker for the next line of treatment. And second here, this is a THP, that is Celeopatra trial, what Dr. Burhan presented earlier on. And if you see the advantage of median PFS, as I said, 6 months. Advantage of overall survival, that's 16 months. But if you move now from first line to second line from the Emilia, because the Emilia and the Celeopatra trial was being done at the same time, once recruitment was done at the same time. So there you could see that moving from one trial to another trial, same patient will be getting now median PFS of 3 months. So it will be drop of almost 50%, and a median OS drop very much. It will be now almost 6 months. So from 16 months to 6 months gap. So why it happened? What is the reason behind that? So you are seeing the graph that is 50% drop in the median PFS. Both the trials were done at the same time. 2012 Celeopatra enrollment was being done, and recruitment as well as the Emilia also. And then came the real world study. What happened? Why these people did not do good with the TDM? If you see that 60% of patients had this pertuzumab in their first line done once they received the TDM. So what has been seen in real world scenario, if you look at the Italian real world scenario, there are two Italian real world scenarios, 1 and 2. Look at here, if a patient had received pertuzumab in the first line and pertuzumab naive. So if they have received pertuzumab in the first line, receiving the second line TDM, the median PFS is 3 months. But if they have not received the pertuzumab, they have received only trastuzumab with the docetaxel or paclitaxel, the median PFS is 8 months. This is the catch, that we should not give PDM in the second line to those patients who have already received pertuzumab. The reason is that if you give two anti-HER2 agents, there is downregulation of HER2 receptor. So there will be HER2 low. TDM is not working in HER2 low status. That is the reason. That was the catch. They could make it from the study in real world studies. That if you see another real world study also, 6 months in pertuzumab exposed and 10 months in pertuzumab naive, if you give TDM in the second line. So the catch is that we should not advocate using TDM in patients who have in the first line used THP, PTH. So again, what I was talking about, the resistance to pertuzumab and trastuzumab may lead to reduced HER2 receptor expression and TDM activity also down. And TDM has limited permeability and is unlikely to impact the tumor cells beyond HER2 positive cells. So it is not like TDX, which will work in HER2 low, 1+, 2+, and it has a bystander effect also, TDX. Coming to now this study, this has been presented, that Destiny 03, that TDM versus now TDX. So because the TDM was the better second line, so they checked second liner with the newer drug, that's TDX. And here you can see in this trial also, 60% of patients had received pertuzumab. Did that affect? And you can see here that median PFS, there is no comparison. It is more than 4 times, 6.8 months versus 28.8 months. And then overall survival is also good at 3.5 years. 62.5% of patients are alive versus 50% in TDM arm. And look at this Foster plot. Those patients who received the pertuzumab, TDM and versus TDX, whether it has received pertuzumab or not received, it doesn't matter. So still we have same hazard ratio, 0.36. So for TDX, it doesn't matter. For TDM, it matters a lot. So we can push TDM furthermore down. But I feel that if a patient has received TDX, TDM has no activity in the third line. We should try to give some other drug rather than TDM. So what are your thoughts, Dr. Nadeem?
Absolutely, absolutely. I mean, very nicely explained. And obviously, I'm considering the data available also. I don't see any point in choosing anything other than this NR2 in second line.
Absolutely. So this patient journey was, see now the journey of this patient. THP 2 years, then progressed, but TDM was given. TDX was not available that time. So TDM was given in the second line, Feb 22, September 2. So what is the, I think these are not 6 months also. So then the
6 months.
TDX was, yes, then the TDX was started. And she developed brain mets also in the meanwhile, and for that SRS was done. What's an experience, your experience regarding that TDX, Dr. Asif, in the second liner or third liner, fourth line?
Sir, even if TDM1 is used, I feel TDXD will be very effective in this patient, and especially with brain metastasis also, because of its bystander effect and very increased payload and other plus points.
Have you used a TDX in your patients as second liner or third liners?
In only one patient, sir.
What has been the response in her?
Yes, sir, excellent. 2-3 cycles, the PET scan was almost 70% reduction was there.
Dr. Satyankar, your experience with TDX? You're mute.
Sir, you are mute. Satyankar sir.
Yeah, largely we have been using in the second or third line only. And yes, the results have not that been great, 6 to 8 months maximum.
Oh, and Dr. Nadeem?
I used it in a one patient only, this TDXG, and that I used in that patient after the usage of a TDM1. So that patient barely took just one cycle only. I mean, she had a permanent brain mets, and then finally she passed away. And I wish if tucatinib would have been available, I would have maybe considered that.
Dr. Burhan?
Yeah, I have used in couple of patients this molecule, and it has actually translated in a very good responses in those patients. But unfortunately for the patient, that the cost of the treatment was so high that they subsequently defaulted. So that was the problem that I faced.
Cost is becoming the problem. We are not able to use as we should have used it, this drug, because of the finance. I have used it in 3 patients. One patient, she had brain, lung, liver, bone. So you name any organ, she had metastasis there. But the performance was good. I used that. She was triple positive in third line. And Alhamdulillah, that patient is very good. She's in CR, no brain, no lung, nowhere mets now. So she has crossed 10 cycles so far. The complications, I think, have anybody experienced any complication of TDX that will be seen in long takers?
Yeah.
So that one of my patient, this patient is a grade 1. She started with, because I am very careful about using TDX in a way that I always ask them about the lung toxicity, because if patient develops lung toxicity, it is almost irreversible. It's very difficult to reverse that. So you have to have a very high degree of suspicion. Only cough, and if she starts having breathlessness on walking, or if she starts having breathlessness while talking to you, so you should suspect and stop the drug, and get an HRCT and try to give the steroids in the grade 1. But grade 2, grade 3, then altogether you have to stop the drug. So that would be one important thing. And second, this drug is giving, it's a very highly emetogenic. It is not like trastuzumab, as we used to give maintenance. Like trastuzumab, patient can come without giving pre-medication, patient can go with the trastuzumab and leave. But this drug is very highly emetogenic. Yeah, I started with from beginning, everything what you give for the highly emetogenic potential drugs, chemotherapy. I use all the regimens, all the 4 regimens for them to prevent the emesis. That is another third. Third is liver toxicity, transaminites. That is to be remembered, and that's to be taken care of well. And fourth is weight gain. My one patient has weight gain. She has become I call her Doraemon. So I don't know her name now. I call her Doraemon. So it becomes so bloated up. I use all the diuretics. The weight is not coming down, but the performance is very good. So these things, but the drug is very good, excellent drug. Only financial toxicity is very much, and this efficacy lies in its payload, and these cleavable linkers and bystander effect. That's the efficacy of this drug. So leaving all that, this has been discussed. Now this patient, suppose this patient will progress after TDX. What are your options? How do you manage this patient? So ILD I talked about, and yes, Destiny Zero, I will leave that because for paucity of time. So post TDX and TDM progression and tucatinib, which profile of patients you will give tucatinib, Dr. Nadeem?
Tucatinib particularly, I will use those who have got unstable brain mets. I mean, so tucatinib is meant for that because it has got a very high CNS penetration, the way it has lapatinib has. So I will reserve tucatinib for that patients only.
If you look at the HER2 climb data, the key eligibility criteria were previously treated stable brain metastasis, untreated brain metastasis not needing immediate local therapy. They had not taken unstable brain metastasis into consideration. They took only stable brain metastasis, either treated or untreated, or previously treated progressing brain metastasis, not needing immediate local therapy. So it has a very good CNS penetration. Again, cost, I think I have not used it. I tried to get it Tokiyasu, and that was very costly. I think it was 3,60,000 for 1 month. And then the patient dropped the idea. Then it was got by, I think, NATCO or BDR. BDR was trying to launch it, but they have not launched it yet. Anybody having any experience of tucatinib? I have not used it.
I don't think.
No.
Dr. Burhan, corporate sector.
Yes, he only may have maybe
No,
having the experience.
we have not used. The reason actually not available was actually the availability of the drug is not is there. Had it been available with any, even with the innovator marketing in the Indian market, so probably we might have used it. But because it is not available, so that is a problem. And most of the patients, once we talk about after TDXT, they have already exhausted there's so much of resources that it becomes practically difficult. Even for panel patients, because it's not available, you can't actually get it. So that is a problem with the tucatinib.
I think tucatinib use will be very limited for all of us. If you see the HER2, this HER2 climb data, the prior therapies were trastuzumab, pertuzumab, TDM. They had not used a TDX that time. So maybe the takers would be very less now in presence of TDX. TDX is available to us. So we will try to use TDX, having very good penetration in the brain as well, and having a very high payload. And you see the response rate is very good, and PFS more than 4 times in Destiny 03. So we will try and look at here the overall response rate here, 41%, and see the median overall survival. It's 4 months difference from the comparator arm. So that's one. And what are the other options? If we see the other options, that is neratinib. Again, you will see here 1.5 month to 2 month improvement in highly treated patients. As Dr. Nadeem was talking about, the neratinib has GI toxicity. So loperamide prophylaxis you have to give. Again, this drug is not available to us. I think it's not available here in India.
No.
So no experiences of that. See the options we have presently at now. This is PTH number 1, TDX number 2, and third line tucatinib, trastuzumab. TDM, I don't know whether we should use TDM in the third line setting post TDX, whether it will be having any efficacy, but there are other options that are available like tucatinib, neratinib, or margetuximab with chemotherapy. These are the options, and same is true with the NCCN guideline. Thank you very much. I think this has been already discussed. Thank you very much for all the panelists for contributing the panel discussion. Over to you, Dr. Nadeem.
Thank you, Dr. Javed, for a wonderful panel discussion and enlightening us. I'm speaking about those practical aspects. Now, moving on to the last talk of the webinar, that is by Dr. Sasha. He's speaking all the way from this Indonesia, and he will be speaking regarding MAMA-core digistain, which has come up a new recurrence score, which is being used in hormone receptor positive breast cancer. And moreover, there was definitely an unmet need because we all are well aware. I mean, Oncotype DX is not available, and I really doubt if anyone of us may have even asked for it, Oncotype DX. So let us see what Dr. Sasha has to speak. This session is being supported by Core Diagnostics. So over to Dr. Sasha.
Hi there, everyone. Thank you very much. Can you hear me okay?
Yes, you are very much audible. Please
Fantastic. And can you see my slides?
Not yet.
Okay, so let me just check that. It does say I'm sharing. I'll stop sharing and try again. I think if it doesn't work this time, I believe I have sent my slides. Maybe someone could post those. Can you see them now? No?
Yes, now they are visible. Now they are visible.
Oh. They're visible now. I wasn't showing
Yes.
them at the time. So okay, so it's me presenting, right? It's no one else presenting.
No, sir, it's me. We are presenting.
Okay, fine.
We
Okay.
are-
That makes a lot of sense. Okay, I'm gonna just come off my screen here so that I can see. I won't be able to see the slides, right? Is that correct?
You can see the slides, sir.
I can from being online.
Yes, you can do that.
Yeah, if you could show me them, because at the moment I can only see myself and Dr. Nadeem. Well, while the slides are coming up, thank you very much. That was a fascinating discussion to listen to just now, the panel discussion, and it just goes to show how difficult your jobs are, because it is not an easy thing to be an oncologist or a surgeon. Can you see? Yes, perfect. Yes, I can see the screens. Lovely, perfect. I am in Indonesia at the moment. I'm in Jakarta, but I am based, that is just purely for business. I'm based in London, in England. And
PDF and
sorry, can you hear me okay?
Yes, you are audible. Please go ahead.
Yeah. Yes, sorry, there's another line there. I am in Jakarta at the moment, but only for business. I am based in the UK. And this is where Digistain is based. And I'm just going to go through a little bit about Digistain. We are starting to make significant inroads in India. We're very, very pleased to be there. And let me tell you a little bit about it. So perhaps if you can show me the first slide or the second slide. Thank you. So let me just see if I can see that bigger. Okay, there we go. So what is Digistain and who is it for, Digistain Breast? It is a risk recurrence test for early ER positive, HER2 negative breast cancer patients. It was developed at Imperial College in London by Dr. Hemal Amrania, who you see in the bottom right of the screen there, with the lab coat on. And we developed this product to create a more even playing field for patients, because companies such as products such as Oncotype and Mammoprint were just vastly too expensive for patients. Now, we do know that in India you've got CanAssist, which is a very viable product, but it is not a molecular assay. It's quite a basic IHC immunohistochemistry assay. So this product is for pre or postmenopausal patients, 0 to 3 lymph positive nodes. So it's either lymph node negative or up to 3 positive lymph nodes. And it provides low risk or high risk results to help you decide if chemotherapy is needed after surgery. The way it works is effectively two software AI algorithms. Dr. Hemal Amrania is a physicist and at Imperial College, and that is where this product comes into its own. So there are two algorithms. The first algorithm reads the elevated levels of tumor DNA that we look at through a spectrometer. The spectrometer, of course, is old technology, and this is why we can charge what we do. We don't have to cost it the same as RNA-based products, for which you need RNA extraction, next generation sequencing. They take a lot longer, they cost a lot longer. So we put an unstained slide in the spectrometer. We have various frequencies and cutoffs that we've worked out, and obviously this has been validated, and we get a result of elevated levels of tumor DNA, which is the biomarker that we look at. And an AI algorithm then reads those results. That is then combined with, on the left-hand side here, you can see at the bottom, number one, the pathology report information that we want: tumor size, tumor grade, lymph node staging, and patient age. There's another algorithm that reads those things, and together it creates a report that shows either high or low risk. Next slide, please. So this is our clinical research team. We have Sir Professor Nick Wright, he's consultant pathologist, head of pathology for Cancer Research UK, and he was the person that discovered the biomarker that we now look at, which is elevated levels of tumor DNA are linked to poor prognosis. And then Dr. Hemmel, as I've discussed, founder, CEO, and lead scientist of Digistain and a physicist. He is the person who then created the way to measure this elevated levels of tumor DNA using spectroscopy. And then Charles Coombs, consultant oncologist, was our lead investigator in our landmark validation publication. Next slide, please. So you've already mentioned in the introduction, you will be aware of Oncotype DX, and this slide shows how Digistain is different to RNA-based tests like Oncotype or MammaPrint. So Digistain directly measures elevated levels of tumor DNA, as we've discussed, with an algorithm, and then this combines this with vital factors of size, grade, and age, stage and age. We're focusing only on the most aggressive tumor areas. We are measuring biological activity in precise areas within a tumor. So rather than averaging signals across the whole sample, we're looking at precise areas. We're spatially specific, which is extremely important, as we all know that tumors are heterogeneous. And we are detecting actual tumor activity linked to poor prognosis. Now, RNA-based tests, although excellent for binary measures like molecular profiling for looking for DNA mutations or RNA fusions, perhaps are not as good as Digistain for predicting risk within 10 years. Although still very good, we have good data. We're not trying to say that these products are bad. They're absolutely not. We just feel that we've created something that's even better and is even more accurate. So RNA-based tests, they estimate risk based on RNA. They're not actual tumor behavior. And they include signals from both tumor and non-tumor tissue. And that there's a risk then that their tests may be diluted by non-cancerous gene activity. The other thing that is important here is that RNA-based tests are ethnically dependent, whereas Digistain is not ethnically dependent in any way. We don't care whether you're from Europe or Africa or India. We are looking simply at your specific elevated levels of tumor DNA, not at any of your gene signatures. Next slide, please. This is an example report, and there's quite a lot of detail here, but really there's only 3 things that a doctor will need to look at. It might be a little bit small for you to see, but I'll draw your attention to it. It's the high risk in red, or it could be low risk. In this instance, it's high risk. The 1.3, which is the Digistain prognostic score result, which gives you the high risk or low risk. And then the 18%. The 18% in this case is a 10-year risk of recurrence if treated with endocrine hormone therapy alone. And so typically our cutoff is 0.98. So if you're above that, you're high risk. If you're below that, you're low risk. Typically it's about 10% in terms of the percentage there. And it's a binary report. We have been told after surveying more than 1,500 doctors that most doctors would prefer a binary report rather than having an intermediate option as Oncotype does. And you can still have that discussion with the patient if they're right on the cutoff. We all have patients that some may be high risk but don't want chemotherapy, some may be low risk but do want chemotherapy. You can still absolutely have that with the cutoff, with those patients that are on the cutoff. Next slide, please. So here are some of our key unique features. We are rapid. We get results back to India within 3 to 5 days, including shipping. That means quicker time to treatment, and that means improving patient outcomes. Oncotype, you're looking at 2 to 4 weeks, normally about 3 weeks, and CanAssist, you're looking at 2 weeks or a bit more as well. We are accurate. We have 99% accuracy at 5 years. This is negative prediction value, which is what all the risk stratification tests are measured on, because we want to make sure that if we say someone's low risk, they truly are. We don't want any false negatives. So 99% accuracy at 5 years, 95% accuracy at 10 years. And we are equivalent to RNA-based testing and actually we are superior in some cases. We also have some head-to-head data with Oncotype, which I'll go through in a moment. And again, I mentioned this before, but we are cost effective and we are much quicker because we don't use RNA. So we don't need reagents. That obviously costs money. Oncotype have to buy their own reagents. Of course, they don't make them. We don't have to do RNA extraction, and we don't have to do next generation sequencing. So we're less than half the cost of Oncotype DX. If you go to the next slide, please. We'll move on. We don't have. I have a few slides, and because we're well overdue, and because I have to catch a flight, I'll move some of the slides. So next slide, please. Next slide, please. Thank you. Yes, independent landmark validation. So this is our independent landmark validation. We have 12.7 years follow-up data. This was published in January 2024. And again, the diagnostic performance, negative predictive value, 99% at 5 years, 95% at 10 years. These were 801 patients who were eligible for this trial, treated at Nottingham City Hospital. And if I go to the next slide, I'll show you the primary endpoints that were statistically significantly achieved. Next slide, please. So we had recurrence-free survival, recurrence, and overall survival. And you can see for all of these three Kaplan-Meier curves, you can see that the arms remained divergent throughout up to 10 years and plus, and over 10 years. You can see that for all three, the hazard ratio was approaching 2, that the confidence interval was tight, and that the p-value was less than 0.001, so statistically significant. So that is the basis why we have the MHRA clearance and the UKCA, and why we're able to sell this product around the world. Next slide, please. This is a slide that has more detail. It just shows premenopausal and postmenopausal, lymph node negative and lymph node positive, and the full population as well, and just shows that we had high results in all of these areas. Next slide, please. So this is a head-to-head study that we have done versus Oncotype DX. Currently, we've got 233 patients that we presented at San Antonio Breast in December 2024, just last December. And we will, by September, have 1,000 patients. So there will be a publication in autumn, maybe not September, but October, between September and November, where we have 1,000 patients. So these were 233 node-negative breast cancer patients that had previously, 6 years previously, had Oncotype DX, and then they were reassessed using Digistain. The endpoint was metastases-free survival, 6-year median follow-up. And then in terms of the low-risk classification, Oncotype scored 50% of these patients as low risk, and Digistain scored 44% of these patients as low risk. It's important to note that all the low-risk cases that Digistain suggested matched Oncotype, so we have strong concordance. But there were some notable exceptions where we said that the patient was high risk and Oncotype said they were low risk, and we'll go through one of those examples in a moment. But overall, we were superior. The AUC curves were superior for Digistain versus Oncotype. So we were superior in this 233 patient data, and we are expecting to see superior data in the 1,000 patients in the autumn. If we could go to the next slide, please. So this is one of the case studies. There are 4 patients that we were not concordant with Oncotype, and the others have not relapsed yet. So we still have to see, because we won't know until 10 years, and we only have 6 years data currently, whether we're truly correct or not. But this patient was scored by Oncotype as 3%. You can see on the table on the right hand side, and Digistain scored this patient at 85% risk of recurrence in 10 years. So why is there such a big difference between us and Digistain for this patient? Well, this patient was node negative, grade 3 HER2 negative and ER positive, 4 mm tumor, age 57, lobular patient, no serious comorbidities. I too, and I'm sure you too, as would you all, suggest that this is probably a low risk patient, judging from just the the pathology report. But unfortunately, the patient received endocrine therapy only and unfortunately died of metastatic breast cancer in 4.8 years. So we were correct. So we're interested to see what these other patients, what happens with these other patients over the next 4 years. But it's interesting. Now, the reason why we think that this may have been the case is due to one of the earlier slides. And if you go to the next slide, we can see it again in summary. Digistain focuses only on the most aggressive tumor areas, and we are measuring the biological activity in precise areas within the tumor rather than averaging signals across the whole sample. We're spatially specific. But RNA-based tests include signals from both tumor and non-tumor tissue, and there is a risk sometimes that this may be diluting the samples, the test, and by non-cancerous gene activity. Next slide, please. And this is the last slide. Currently, you know, in India, doctors send us samples by FedEx or UPS, etc. It's a very simple process. The requisitions forms done online on DigiHub. We get sent the FFP. It's just a simple FFP block, either that or a one H&E stained slide and one unstained slide. We put it through a spectrometer. We provide the results straight away via the cloud, so the doctor gets it very, very quickly. Now, we have developed this product to be able to be done in-house. So right now I'm in Indonesia because the biggest cancer center in Indonesia, Darmais Hospital, they look after a catchment area of 10 million people, but actually they have their referral center for the whole of Indonesia for cancer cases, not all cancers, but for special cancer cases. So they will be putting a spectrometer in-house. South Africa are doing a similar thing as well. We haven't come across that with India yet. Currently, that's just being sent to us via shipping, but it is absolutely possible. We've created a solution that the pathology department will have everything they need except for a spectrometer. And so it's an elegant and simple solution. Thank you very much for your time. That's the end of my presentation. Any questions?
Thank you, Dr. Sasha. I mean, really, I mean, after listening to your presentation, I think it will be criminal if I don't ask any patient of hormone receptor positive, HER2 negative early breast cancer for not undergoing this digistain. I mean, because the way you have present in one of the slides that it has been compared head to head with this Oncotype DX. I mean, that is the that in fact, looking at the NCCN guideline, only Oncotype DX has been written that it has got a category 1 recommendation, especially for post-menopausal patients. And moreover, I mean, this has been you have shown that it has been clearly proven in head-to-head comparison equivalent, or rather, I mean, better than Oncotype DX. But I still wonder that in spite of this such a study, I mean, I'm yet to see in NCCN guidelines even the enlisted names of this digistain there. I mean, whatever this gene expression assays there I got, I mean, they all have been mentioned that they are just prognostic. I mean, not predictive of a benefit to chemotherapy. But looking at this digistain, I mean, when you have compared it with Oncotype DX and rather proved to be as good as Oncotype DX, so we can rather say that it is predictive and prognostic both.
Yes, I'm happy to. There's a couple of things that you've mentioned there, and I'm happy to sort of go through both of those things. First of all, guidelines. I think Oncotype, when did they come on board? About 10 years ago, was it? 8 years ago, 10 years ago, something like that. So they've had a long time. When they came on board and they got NCCN, when they came to market, I mean, and they got NCCN guidelines and NICE guidelines, they had about 250 patients in there, between 250 and 350 patients in there, all of the risk stratification tests, mammoprint as well, in their validation, right? We have 800, so 3 times the amount. But we haven't got those guidelines yet because they take time. So we are in the process of getting NICE guidelines, and then we will follow up with NCCN guidelines. The process takes about a year or two, depending on, and so we think we've got about another year left. So they take some time to go through. We will absolutely get NICE guidelines because they want to halve their costs in the NHS with us. So that's the first thing. We haven't got the guidelines yet. but we will do. But this is still completely usable. So, for example, in the UK, every single private insurer has done due diligence on us, deep due diligence, and reimburses us. So everyone in the UK, all the private insurers in the UK, AXA, Bupa, Vitality, Aviva, they reimburse us. The second thing is about the predictive versus the prognostic. Actually, none of our tests are truly predictive. No one does chemotherapy sensitivity testing. I've worked with chemotherapy sensitivity tests. Oncotype doesn't do that. We don't do that. Mammoprint don't do that. What Oncotype have done, quite very cleverly, is they've done a study to say, well, out of the high-risk patients that we've said are high risk, do they generally do better with chemotherapy? And that makes sense that they do. And of course, the study found that they do indeed. So they've done zero different. I think it was a worthy study. I think it was good. It was good to show it. I think it's good because it actually benefits all the publication, all the risk stratification tests. But it just means simply shows if you're accurate with your low risk and high risk, and you give chemotherapy to high risk, then they are likely to respond. That's simple as that. There is no drug sensitivity testing of any kind. So none of us are actually predictive, but we are in a way as well, because if we're accurate, those people who are high risk will benefit from chemotherapy.
Okay. And then one more thing. I mean, what is the cutoff for the number of positive nodes for which you will ask for a DG state? I mean,
Yes. Lymph node negative, so 0 to up to 3 positive lymph nodes.
Yes, like we use it for other assays. Okay.
And it's for pre or post. I think someone's got their hand up. Is Dr. Javid?
Yes, Dr. Javed, please unmute yourself and ask.
Yes, Dr. Sasha, very good presentation. And since we have actually your representatives come to us about the disease scan, so we are slightly, not comfortable yet. One reason would be its legal application in India, because Oncotype DX has FDA approved product, and it is in NCHC and guideline as well. So anywhere, if we ask for the Oncotype DX, many of our all patients don't afford it. I have some patients only where Oncotype DX was done, and can insist I have done, and I think again there they did basically all those tests on team trial patients, and they validated their results with the Oncotype DX as well. So that is based on the proteomics, and yours is on the genomics, probably because it's a DNA based test.
It's a molecular assay, yes. Yeah, it's elevated levels of tumor DNA. Look, I hear what you're saying, absolutely, and I accept it, and I think that it would be a much easier sell for Digistain once we have guidelines. By the way, I do not believe the Oncotype is FDA approved. They do have NCCN guidelines though, but the product itself, no. But either way, they definitely have NICE. They definitely have NCCN, and we are yet to get that point. From a legal point of view, there is no legal necessity to have NCCN guidelines or FDA or NICE. But I totally accept that it's like another checkbox to feel confident about the product. I accept that. I also accept that Canacyst has Indian data. We are not ethnically subject to any ethnicity issues at all, because we're simply looking at the elevated levels of tumor DNA. So it's one of the positives with our product that we can be in any part of the world and not have that. But we do realize that it takes a little bit of time for people to get their head around it. And that is why we've gone in not at 20% less or 10% less than Oncotype, but half the price, less than half the price. And so
yeah, that's absolutely one more point, that what's the duration, follow-up of those patients where Digistain was used as a prognostic marker?
Yes, 12.7 years follow-up. So we
Yeah,
have
27
we
years.
have yes, and so CanAssist, as you know, only has 5 years. We
Yeah.
have we have 10 full years. I mean, we have done 12.7, but we record the just like Oncotype, everyone does 10 years. So
What has been the recurrences? How many recurrences in 10 years on those patients who were hormone positive?
so we have a 99% negative predictive value at 5 years and 95% at 10 years. That's what we have. But I will, and that's from the study. Now, from a clinical point of view, we've been doing this. Although we only published our publication in January 2024. Excuse me. We have been clinically selling here and there for about 3 years, and it should be noted that we have not had anyone that we said has been low risk that has recurred.
Okay.
Yeah. However, something interesting just happened. Just as if I can just very quickly finish. There was an anecdote. It's just anecdotal. It's not scientific because it's one of one. But 2 years ago in Indonesia, we got a case from Indonesia. We got the biopsy, we got the pathology report, and we did the test, and we said it was a low risk patient. And then 3 days later, they said, sorry, we got the pathology report incorrect. It's not a lymph node negative patient, it's a lymph node 1 positive patient. So we redid the test, and the test came out high risk. Now, they were not happy with that because they thought, hang on, but if the doctor was looking just with his eyes, you would still think it's a low risk patient. It's only one lymph node positive. Nothing else has been changed. But of course, it's AI algorithms that are looking into lots of many features. Unfortunately, I've been told when I've just been here, 2 weeks ago, that patient died within 2 years. So we were correct. I don't take any pleasure from being correct here, but we were correct that this patient was high risk. So it is something. You will all have patients when you look at them before you do any test that you think are low risk or high risk. You are just confirming with the products, and I'm just giving you an example that many times we can be right, but sometimes we just on our sort of naked human eye, we just cannot see this.
Exactly. I have quite a good experience of now on CanAssist breast. I think on my follow-up around 35 to 40 patients where I have done CanAssist breast so far. And my longest duration patient, which I am following, has crossed 3.5 years.
Excellent.
So till now, no recurrences because it is a new product again. So
Yes.
I am always having the anxiety that this patient should not recur because I don't have a full confidence on the data. But somehow I continued 3.5 years. My one first patient, which is following me. I have done that test in patients who were hormone positive with node positivity in postmenopausal setup as well. You know, up to 3 nodes. There are some patients like 3, 4 patients like that also, which are on follow-up, but none among the premenopausal who had node positive. I didn't do that test. Some I did, it came high risk. So I clinically super select some patients for the CanAssist. So, which I thought, as you also said, which I thought that is a low risk and should behave like a low risk hormone positive disease in premenopausal setting as well. Those I selected for CanAssist, but none for the node positive in premenopausal. But postmenopausal, yes, I did because Oncotype DX is validated in the hormone positive in node positive as well in this postmenopausal setting. So up to 3 nodes, yes, you can take them. And if they are low risk, you can continue to give only hormone, no need to give them this chemotherapy. So similarly, I have 3 or 4 patients who are node positive, but postmenopausal only, where the score came low, less than 15 as per the this CanAssist breast. So 35 patients on follow-up. Let us see. I will wait for all the 5 years. Let us see how would be the disease dynamics in them.
Very good, very good. But thank you very much for your time, everyone. I have a driver in just outside waiting to take me to the airport, and he's been there
Thank
for
you.
half an
Thank
hour,
you.
so I've got to go. But yeah, do consider Digistain, and obviously Core can provide all the validation papers, etc., any information that you require.
Thank you
Thank
very
you.
much.
Thank you. Thank you.
Take care, everyone. Bye-bye.
Thank you. Thank you, Abdullah and team, for a wonderful organization. I mean, for organizing it so nicely. So, thank you.
Thank you, sir. Thank you, sir. Welcome. Good night.